you talk, and I completely agree with your comments on Dr. Unni Krishnan sir. He is the leader and we are just working as a team. He's staying on the earth and working on the Mars. So excellently said. Sir, one question for you. This digital technology is really a blessing for diabetes patients. Have you, in your clinical practice or experience, have you seen some negative aspect of this technology as such?
No, overall the technology is helpful, but we must use every technology with respect. So we should know what the apps can do for us and also what they cannot do. The app will not replace medical supervision, for example. And in this conference, we have booths as well. So there is a virtual booth number 7, where you can go and there will be staff there to help you with learning more about the BD app, how it will be launched in India, how you can use it, what are the training materials that you can get for this. So I'd like to invite all of you to join, to just explore the conference platform and find out the virtual booths and look for the BD booth. So do use the apps with respect, with caution, and remind your patients that they are there to supplement, to complement our efforts, not to replace them.
Perfectly said, sir. We don't have any further questions, so we would like to...
Can I ask Dr. Kalra a question?
Yes, sir. Please go ahead, sir.
Right. Sanjay, with too many apps, a glucose meter person will have an app now. The insulin injection needle people will have an app, and insulin company itself will have a coaching app. Where does it take the patient? Is there a strong need for integration and not individualized apps from every different vendor?
You are right. There is a need. So let us look at it from an educational perspective. Everybody needs primary education. Some of us go on to secondary and others go on to tertiary education. So it is primary education which is essential, which is mandatory. That would mean learning about basics of diet, basics of nutrition, basics of insulin technique and insulin titration. So that app everyone should have. Once you are comfortable with that, you may choose to go on to secondary training in the educational system. The secondary or tertiary education that we seek, that can be vocational, it can be academic. So based upon your needs, you might wish to download an app which focuses on insulin device only. Yeah, you might wish to download an app which focuses on other complication management. So that would be up to the individual. So based upon the individual's literacy, numeracy, and also skills, we can tailor our counseling. And it's not that you have to tell the people living with diabetes that I am limiting you to a primary care app. The BD app is something which will offer both primary and secondary services. And hopefully in the future, it will expand and evolve into a way that tertiary care is also taken care of. But we begin with a primary app. The BD one is a good example. And based upon each patient's requirements, wishes, preferences, we can always add more apps to that person's smartphone. But this concept will help us understand what to say to which patient.
Oh, great.
Thank you, speakers, Dr. Kalra sir, Dr. Chawla sir. Thank you, chairpersons, Dr. Nikaje sir and Simi Dubey ma'am. It was pleasure to have you all. Now moving ahead for the next session, I would like to invite Dr. Deepanjali Pawar to chair the session. Can we have CD slide of Dr. Deepanjali? So Dr. Deepanjali is a good friend of us, and she is consultant diabetologist at Satara, works at Satara Hospital Research Center and Siddhivinayak Hospital. She has multiple publications to her credit, and she is doing a lot of philanthropy, and she is a renowned and liked doctor in Satara. Over to you, ma'am, to start the session.
Thank you. Good afternoon, everyone. I would have your attention, please. I would like to welcome you all here at the 6th International Diabetes Summit by Jalaram Diabetes Institute, Pune. in association with API Pune. So today's session is about entrepreneurship in diabetes care. So our first lecture is from a renowned endocrinologist from Indore, Dr. Sunil M Jain. He's delivering a lecture about building a high quality diabetes care team. As we all know, Dr. Sunil M Jain, no words are enough to introduce him. He is a well-known endocrinologist in Central India. He has done MBBS and MD from Gandhi Medical College. After pursued DM in endocrinology from PGI Chandigarh, he practiced since 1995 and he had authors of many titles. Dr. Jain has many publications in medical journals. Diabetes Hormone Institute named Total in his New Dream project for the world in diabetes, thyroid, and other endocrine disorders. He has an institute named Total, which is devoted to endocrine diseases. It is also modeled on diabetes, the theme of diabetes. He is also doing research center on endocrine and related diseases. So he is well known for his work as it's really genuine, and along with his team, he is doing the great service to serve the society. So I request Dr. Sunil M Jain to please deliver his lecture.
All delegates, I am thankful to Dr. Unni for providing me this opportunity to interact with you on building a high quality diabetes care team. I am Dr. Sunil M Jain, working at Total Diabetes Hormone Institute, and we have a team. So I think because of this, Dr. Unni has asked me to talk on this particular topic. Now we understand that diabetes care requires a teamwork. And this is the ADA 2022 recommendation on how comprehensive diabetes care has to be. So we have to understand what is the current lifestyle of the patient, what are the comorbidities, what are the clinical characteristics, individualize care, define, discuss with the patients, create a management plan, implement the management plan, then have a lot of support system. Obviously, this much task, a single clinician sitting in an office cannot do. So it requires a teamwork and how to build up this team. Let me give you my own experience. I did my DM in endocrinology in 1995. And for 5 years, I worked in a solo clinic. I had my own clinic, single person operated, and I was working there. In a period of 5 years, I realized that to transfer a comprehensive diabetes care to a patient by a single individual is a difficult task. And that's what finally motivated me to create a team. So 5 years after my practice, I entered into the teamwork. So last 22 years now, I am working with a diabetes care team, which I developed, which are working with me, and that's how we are working since last 22 years now. And that's what I'm going to share my own clinical, my own experience, so that if we want to develop a diabetes care system, what are the important things which should think of when we are planning for such an objective? So there are different ways of working on the same project, but this is now my personal views which I am going to share with you. So I think when we are creating a team, our 5 most important objectives should be: 1, we should not only offer a quality care, but it should be complete, comprehensive quality care is needed by such a team. That should be one objective. And obviously for that, we will require a manpower, a team, which we are going to discuss. Very important. Whatever is our prescription, if the patient didn't understood the importance of the therapy, they are not going to follow it. So very important that patient should understand and get satisfied with what we are doing. So patient satisfaction, this is another big component of teamwork for success. Data keeping, record keeping is very important because this is a chronic lifetime disease where we want to see the disease progression, how the patients are changing. Whether it is hard copy, whether it is soft copy, we understand the current, it is a digitalized word. I, in my center, keep both. I have a hard copy as well as soft copy data, which we are serially following with our patients. So I think a record keeping component is also very important. Then we must look at our economics also, because this requires a big team. And here there is no big surgical procedures involved like in cardiac surgery, neurosurgery, orthopedic surgery, it is going to happen. So we must look at our return on investment, what we are investing to build up a setup and how we are going to run it, because ultimately it has to sustain. It has to be for long term. So we have to plan a strategy accordingly. And many times, many of my friends come and discuss with me about building up a center. I always tell them that to make such a teamwork, you have to look these objectives and then create your own setup. If you are very clear right from the beginning, then there won't be any hassles. It's easy. What are the important components of a diabetes care team? And I'm talking of a high quality diabetes care team where what objectives we have discussed, we want to fulfill them. So obviously you have to build a good manpower, a team of people who are going to work in the center. That is the most crucial component, that is the HR component of the team. Then right from the beginning, we have to determine and decide what facilities and services we want to offer through this team. Now here, you can offer right from the basic diabetes care only and refer the patient for the other allied services like nephrology, cardiology, retinopathy, ophthalmology, food care to other experts. Or you can go up to a setup which can offer all micro and macro angiopathy management at one setup, which obviously then become a bigger hospital service. So that has to be determined by the head of the department who is going to do what level of facility and services they want. But my suggestion will be that diabetes care management comprehensive should be the must. Then depending on what area you have, according to that, we should plan our space and layout. That is a totally individualized area, which everybody has to determine and decide at their end. And in this world, we cannot sustain or create a high diabetes care team without a technology support, without digitalization. So consider technology as an important component of the diabetes care team. And then you have to be an administrator. You have to be a training personnel, because when I am delivering this presentation, I am considering that an endocrinologist or a diabetologist is now creating a diabetes care team to deliver comprehensive care. So that means you have to look after these major 5 important components. And if you can focus on these 5 important components rightly, it's easy to create a good quality diabetes care team and deliver the diabetes care services. Let us talk one by one each component now. So let me talk about manpower. Now, manpower. One, you have to first decide what level of experts you want to keep with you. If you want to go into just diabetes and manage, then you are alone sufficient. But if you want to start a retina unit, obviously you need an ophthalmologist. If you want to start a foot care services, OT services, then you will require a full foot surgeon and maybe a plastic surgeon support. If you want to go in, and I believe that up to these two is enough, because then the nephropathy becomes a whole specialty in itself. Cardiac unit becomes a whole specialty in itself. So in my opinion, manpower means it should be a expert in the field of diabetes along with the support from ophthalmologist and foot care expert. These three are the essential components when it comes to medical experts. And along with diabetes expert endocrinologists, they must have a good quality MBBS or MD support system working with them. Only then we can deliver a comprehensive care. So that is the manpower component from medical expert side. Then we have to have few people who can be called as diabetes counselor. For example, I have developed a system called My Sugar Plan, where we try to explain every patient about what diabetes is in few minutes. And these are important patient engagement areas also in the OPD. So patients learn little more about diabetes before even meeting a consultant. So these are the few people who can transfer you good information about patient's mindset and their barriers as well. And a dietitian or a nutritionist will obviously an essential component of a diabetes care team. And then apart from these two people kind of manpower, we need one more person. And this person is very important in the current era, where we are having CGMS, we are having insulin pumps. So I call them technology experts on. So in our center, we use the word insulin trainers for them. So their job is to train insulin, glucometer. If I ask them put this patient on CGM, they can put CGM. If I ask them connect this patient on insulin pump, they can connect the patient on insulin pump. That kind of manpower. And with my experience, for such manpower, we do not need to have any high qualification. We need to have a local person who should be sustainable, who understand at least English, communicate with the patients well, and good trainable. Train such people, and they are good asset who can train our patient on insulin, how to use meters, CGM, insulin technology, etc. And one more component, because in such a center, most likely a pharmacy will be required. And even if pharmacy is present or not, doesn't matter. We need another person who should be expert in training how to explain the prescription to a patient and resolve their queries. I see most of the time doctors do this job in our country. But I tell you, this is an area where a lot of time is needed, and this is very important from patient satisfaction perspective. And for that, if a dedicated person who explains the prescription to the patient is kept, that will be a very good add-on to a diabetes care team. And obviously, you need manpower. Technicians to the services which you are offering, if you have done a neuropathy testing or a peripheral arterial disease testing or autonomic neuropathy screening, ECG, X-ray, these where you need always technicians who are going to do their job. So manpower selection is extremely important in a diabetes care team. And we should define these kind of different manpowers who are now finally supporting us to provide the final goals and objectives which I discussed in the initial slide. Facilities and services I already talked, right from a good reception, then somebody who is organizing the medical records of the patient, then consultants, support systems, which we already discussed, and then the investigations, including from lab to whatever complication screening services, fundus examination, and then if you require, you can open up a ophthalmology unit where the retinal angiography, laser, etc. also can be done. Minor OT, major OT, where podiatry and the food surgeries also can be done. And a small inpatient service can be kept if we are handling such class of patients. We need to develop one team which will be specifically talking about pregnancy diabetes and type 1 diabetes care, because these are very specific area which consume a lot of time. So I already discussed the supporting manpower to you. You can select few of them, like a diabetes counselor who can be trained more on type 1 diabetes, who can be trained more on pregnancy diabetes also. And they can deliver some information, and that's how we can make our time management easy. So these are the facilities and services where, apart from consultation, I consider education and patient empowerment is a very important component of the diabetes care team. Just a prescription doesn't work in diabetes. So the education has to be transferred once patient in our diabetes center. And for that, we need a big team. Then laboratory, essential investigation, complication screening facility, retina, foot care. And I think we cannot manage now without a diabetes technology unit. So that's what I emphasized on the need of a technology person should be component of the team who should be able to handle all diabetes technologies. And if you require, you can consider inpatient service as well. Space and layout has to be, depends on what space you have, but suppose you have a limited space, then my suggestion that focus on diabetes care primarily. Then don't go into allied specialties. You go into allied specialties only when you have a larger space. And then the most important component of the today's world, technology support. We can't go beyond that. Technology, digitalization, computerization, app management, this is important. And I have a keen interest into this field since last, say, more than 22 years. And I am into software technology development since last 20 years. And now came out with many products, including one for clinics also, through which you can manage all these areas which I have mentioned here to minimize waiting time, time management, patient empowerment, transfer the diet related a lot of information to the patient, get them involved. And here, one important point, there are so many internet doctors now coming up, which are the technology competitors of the consultants who are working in their clinic. So through this digitalization mode, you can handle many things. So there is an important role for this technology intervention. This is a big one-day topic in itself. And then training and administration is a very important area. And it is the responsibility of the head who has created diabetes care team to train their manpower. Keep taking their own sessions. And that's what I have doing since last so many years. And communicate what you want from them. And if we can do only then we can achieve the goal. So these are the essential team members in a diabetes care team, diabetes expert and their support systems, ophthalmologists, podiatrists if required. You should have good diabetes assistant doctors, train them, educators, technology experts, dietitians, prescription explanation people, phone call managers who can handle many things, good reception and OPD managers, and data entry staff. And that's what my experience says, that if you want to build a high quality diabetes care team, it is essential to define initial goals, what you want. First, be very clear on this. Then create a strategy, and accordingly you plan your layout pattern in your center. Create certain standard operative procedures that I am going to do, my team should work like this. Add a lot of digitalization. Keep doing training of your team, and that's how you can always ensure sustainability. And that's how we can create a high quality diabetes care team. Thank you very much.
Thank you, sir. Actually, sir had used his years' experience and hunt to understand the strategy behind this whole process. I have myself completed a certification course from his institute. I have seen that the top floor of his institute is dedicated to research. First floor is dedicated to the new facilities and diabetes care unit, while the basic floor and the hospital and clinic and lab all over. What he's talking about is actually his years experience. Thank you, Dr. Jain, sir, for giving us or enlighten us with your knowledge. So let's move on to the next lecture.
Can we have the CV of Dr. Santosh Ramakrishnan?
Or can we take the questions? Okay. So let's move on to the next lecture. Next lecture is about the topic is the doctor as an entrepreneur, how I think, by Dr. Santosh Ramakrishnan. Dr. Santosh Ramakrishnan is director and endocrinologist at Magna Endocrine Clinics, Hyderabad. He has an outstanding profile in academics and research. He is foremost among the rising star endocrinology entrepreneurs of India. So I would like to invite Dr. Santosh to share his view on this topic.
Everyone, I'm Dr. R. Santosh. I'm the consultant endocrinologist out of Hyderabad. So today I'll be talking about this topic, the doctor as an entrepreneur, how I think. So basically I'll let you through my life story. Then you'll understand how I end up thinking or how I do. So my path of success was desired like this. So I studied hard till my 10th standard and I got good marks in 10th standard. Yes, I thought that was a good success. Then I got into one of the leading junior colleges in Pune. Good. I thought that was a huge success. I got good marks in 12th standard and I landed up in one of the best places to do an undergraduation in MBBS. That was counted as success. Then I ended up doing PG internal medicine in JIPMER and then DM endocrinology in PGI Chandigarh. And finally, I ended up getting a good job at a leading corporate hospital in Hyderabad. So I thought, yes, I have achieved everything that I've set out to achieve. As soon as I joined this corporate hospital, I came to know that this was the leading hospital of that particular city. I had a good pay. The fame was instantaneous. I became famous as an endocrinologist soon. There was ready appreciation for whatever I do. It was a 9-to-5 job, and I already started getting a lot of talks as far as academics were concerned. So yes, again, I thought I have already reached the pinnacle of my success. Life is complete at the age of 32. That's what I thought. Or is it? Now, here I want to throw in some insights and I'll let you know what exactly happened in my life, why it changed when I was around 32 to 34, what exactly happened at that time. I started realizing some flip sides. I was in a corporate hospitals where I was mandated to take 6:30 a.m. phone calls every day to know the fasting blood glucose of the patients admitted in the hospital. Every day, each and every day. So it included Sunday, it included holidays. Every day I had to get up at 6:30 a.m. for the same. 8 p.m. I never watched a movie. I never drove at that time. I always used to get pre-dinner phone calls at that time. Sunday rounds used to be a long drawn thing because patients used to always wait to talk to us on a Sunday because they knew that we were a little bit freer on that day. And we ended up preparing for so many academic talks. One day I came across this particular wheel of life. This wheel of life actually threw my life open. And then I realized that what I have actually achieved till the age of 32 is nothing probably. If you look at life, it has so many other aspects to it, except not just, getting a good job and, getting famous and probably getting good salary. It has so many other aspects in life. So I prepared my own wheel of life at that time. This is a true image which was done from that time. You can see there that I put a 0 in the center and then drew some spokes. If you are having free time, you can actually follow it and do it right now as I'm speaking. From 0 to 10, I marked where I reached as far as my professional life was concerned. From 0 to 10, as far as academics were concerned, family, exercise, giving back to society, friends and hobbies were concerned. So if you have achieved whatever you set out to achieve, this wheel of life should be a perfect circle, is it not? Because you have achieved everything that you have achieved you wanted in life. Then I realized at that particular moment, how far did I get in my life at that part? Professionally, yes, I have achieved a good job. I'm getting a good 9-to-5 job, good pay. 9 points out of 10 is what I achieved. Finance point, probably 3. I was just young in my career. I have not achieved whatever I wanted to achieve as far as finance was concerned. But academics, yes, I've got my DM in endocrinology from PGH Chandigarh, and I was one of the preferred to go-to speakers in the city of Hyderabad. I was very happy. But then came the other things. Family life sucked. I spent very less time with my family, only 3 points out of 10. Friends and socializing. Meeting friends in the hospital it's just a professional courtesy. It's how often are you meeting friends? How often are you socializing? 2 points out of 10. Exercise. How much exercise was I getting? 2 points out of 10 only. Hobbies. How much time was I spending with the hobbies and significant others? 2 points out of 10. And what was I giving back to society? 2 points out of 10. So if you see my wheel of life at that particular moment, it was like this. It was nowhere resembling a wheel. It's come as something as an odd shape, is it not? So what I thought I had achieved at the age of 32 was nothing but a professional part of it. And so many aspects of my life still remained undiscovered. That's when I decided that now I cannot, continue to work under somebody. I need to have the time in my own hand. And I decided to turn to entrepreneurship. This is a particular story that I want to talk about, the growth clinic story. So in the corporate hospital where I worked, it took me a long time to convey to the management that children who are growing might need a clinic where they need to check their height and pubertal status and weight and etc. So after 8 to 9 months of convincing, the management in the hospital told, okay, we will give you 15,000 rupees to start the growth clinic. 15,000 rupees was the sum that I was given. So what I decided with this 15,000 rupees is I made 3 standees and put it in different parts of the corporate hospital where I was working. Just by looking at those standees, I had 200 parents coming and meeting me in the first 1 month itself. Obviously, out of these 200 parents, more than 150 were just over-concerned parents. Their children were absolutely normal. But the remaining 40, 45, we managed to scale rare genetic disorders, rare hormonal disorders, which affected the growth of the child and the development of the child. We ended up doing so many examinations, so many investigations, and treatment was given at the correct time to the correct children in such a way that the 15,000 that they had invested had turned out to be an 8 lakh initiative in the first month itself. Immediately, whatever the idea had done was scaled into 4 to 5 centers of that particular corporate hospital. Basically, I sold my idea to the corporate hospital. Then I realized that, hey, doctors are also not that bad as an entrepreneur. Even we can have some good ideas that can actually be scaled. But looking at that, they decided that, this person is having a little bit of a different capability. He's able to think offbeat. He's just not seeing patients and going. So they made me one of the leads in their diabetic clinic initiative in that particular hospital. And the reporting system was awesome because I was reporting directly to the, the CEO. I was reporting directly to the directors of the hospital. I was very happy with whatever I was doing then at that particular moment. Then soon I realized that this was a leadership by assignment. Basically, they told me, we have done this. Now you are the leader, you're supposed to take care. Whereas a leadership by contribution was missing. I was probably not contributing anything to developing the whole diabetic clinic initiative. I was just a leader. I was just a front face in front of it. So probably I was getting less and less satisfied with whatever was happening at that particular moment. I went back to the source which told me about the wheel of life. Then I sat back and I decided, what do I value the most as far as my profession is concerned? Do I value money the most? Do I value recognition on power? Do I want security? Like, do I want some backup always? Do I value quality of life? Do I value academics more? Do I value autonomy more? So I decided the quality of life and autonomy was probably the ones, excuse me, the quality of life and autonomy was the one that I was really, really wanting to carry forward. I heard about this bird catcher story around about then. What is this bird catcher story? So bird catcher story is rather an interesting story. So in Maharashtra, there are certain groups of bird catchers who use a very unique way to catch the birds. There is a twig which is hung to the branch of a tree with a thread. So there's a branch, there's a thread, and there's a twig that is there. Birds usually come and sit on the twig. And because of their weight, the entire twig will reverse. And what will happen is the bird will be hanging upside down. Now the bird has never seen the world from an upside down position. It holds on to the twig very tightly because it has never seen the world in an upside down position, and it decides that it should not fly from here because it has never seen the world this way. The next day, the bird catcher will come, remove the twig and catch the bird and go away. Now, what was the catch in this particular story? What did you understand? I realized that I was the bird. So in the twig, which was hanging upside down, I was hanging onto the twig. I thought that twig was my security. I thought if I left the twig and started going on down, I would rather hit the ground and crash. I didn't know at that time that if I left the twig and started going down, I'd probably go down for some time, then again start flying up and escape. So that is what the bird catcher story is. It says that the twig was giving you a false sense of security. You're just holding on, thinking that if you left the twig, you're actually going to hit the ground and crash. Whereas you yourself know in your mind that you'll actually go down only for a certain time, then you'll start flying and then you'll fly far away. And that was the moment that changed my life. I decided that, I should take entrepreneurship into my life and continue the same. So when it came to entrepreneurship, and if you want to gain time on your social aspect, on your friends aspect, on your family aspect, then we must optimize the work. We must get good productivity with less time as possible. So how do we prioritize the job we do? For that, we need to understand as doctors, where do we waste maximum time? Maximum time we waste in context switching. So we are not able to concentrate on one thing at one time. You'll end up seeing a patient in between. You'll talk about some academics. You'll be calling up and fixing up some talk. Then you'll be talking to some secretary and, trying to get your tea on time or something like that. Keep context switching instead of concentrating at the job at hand at one time. Repeated communication. You keep telling the same thing again and again, either to the patient or to the staff. Most important thing is not delegating your work. Now I'm going to go a little bit in detail about that. Distractions. Continuously the phone is ringing, some notifications are coming, and mishmashing. You are confusing one job with the other and mishmashing it from here and there. So basically tasks, we were divided into tasks that I love to do. Now, as an entrepreneur, obviously, I would like to find out at every time what my staff are doing, what is the cleanliness, how are the patients behaving outside my room, what are they doing. Then I had to divide into tasks what I'm good at. Obviously, I'm good at this moment at seeing patients itself, and tasks that need to be done as a doctor, as an entrepreneur. If you're able to define what tasks that need to be done, what you're good at and what you love to do, you'll find one area which you actually need to concentrate on. Tasks have to be divided into two. that those can be delegated and those that cannot be delegated. Delegation will definitely come at a cost, but if it comes with good quality, it will help you to save a lots of time. I remember when I told one of my colleagues that we were actually spending a certain amount of money per month on our staff welfare and management, he was shocked because he was probably spending only 1/10 of what I was spending. He was saying, "Are you mad? Why are you spending so much time on so much stuff? Do you really need that?" So I told him, "Boss, see, I've just started my work. You just see where I am after 3 to 4 years, and then we can speak." Needless to say, I'm probably earning a little more than what that person was earning right now. Delegation can be done by the following ways. So there are some tasks which only I can do. For example, as a doctor, only I can see the patient, make a diagnosis, and decide what treatment the patient should be done. So this task has to be done by me. There are some tasks which other people can do, but I must do that. For example, writing down the prescription and explaining it to the patient, others can do it for me, but I must do it because that's what the patient has come inside for, is it not? I can do, others can do. For example, to take the history of the patient. Now, what has the patient, since when the patient has diabetes and what treatment has he been taking, all that. Somebody else can do it. I can also do that. So if there is somebody to help me, good. If there is nobody to help me, I should be doing that. There are some things which I can do, but others must do. For example, checking the blood pressure, checking the weight, all that need not be done by a doctor. It can be done by even your front desk staff. It can be done by a nurse outside. You can save so much time by somebody else entering the vitals of the patient rather than you having to do it. And there are some things which others can do. For example, a diet should be told by the dietitian only. Billing should be done by the front desk person only. It should not be done by you. That's where you end up spending a lot of time in doing things where you should have saved time rather than wasting time on it. Delegation, it's very important to understand that frequent follow-up versus too frequent follow-up is also important. So if you have told your staff, for example, that outside your room, one particular poster needs to be hanged, you should not get up after every patient and check whether the poster has actually been hung or no. If you have told your staff that, why don't you do it? You please follow up after one day, or you follow up in the end of the day, rather than going out every time, finding out that they have not yet hung that poster, and then you end up fighting with the staff and losing your temper and getting anger. You need to find out what is urgent and what is not urgent. So this is what I was trying to tell you. What is urgent and what is not urgent. For example, treating the patient who's sitting in your room is urgent work, and it is important work as well. So it's very important. For example, preparing this talk is a very important work for me, but it's not urgent. There are some works which are very urgent. For example, the patient needs to be, his BP needs to be checked, his height, weight needs to be checked. But it's not important that I do it. Somebody else can do it for you. There are some works which are neither urgent, not important. So you should keep it last only. So if you know what task to do when, definitely you will be able to prioritize and do the works one after the other. Leadership can also be done. So basically, when you're delegating, you're a leader, is it not? You're a leader of whatever is being done. It can be done by example or by force. Now, I'll just give you a simple example. You are taking rounds in a hospital and you have come to a particular patient. One particular injection had to be given to the patient at one particular time. And the nurse has not given that injection to that particular patient at that time. You can do two things. You can either blast that nurse in front of the patient so that she feels embarrassed and she starts crying, that why you are not given this injection at this particular time. There's another way of doing it. You'll just say, nurse, why don't you load the injection right now? The nurse will load the injection and you give the injection to the patient yourself. The nurse would have learned a superb lesson on that day. Without you shouting at that particular nurse, without you increasing your BP, you have made her feel guilty. You have made her feel down actually, and she'll never forget that in her life. She'll never forget to give the injections on time. You have led her by example, and she'll continue to respect you throughout your life. Rather than blasting her and getting the work done, you just led her by example. You made her you feel bad and follow that example throughout your life in such a way that she'll always remember you. Now, After you have managed to optimize your work schedule, you should try to find out to optimize your life as well. So children are one of the most important things that you need to take care of. You are the bows from which your children as living arrows are sent forth. You are not the arrows, basically. You are not supposed to tell the child, why don't you go here, you go here. You are supposed to be the strength. The child wants to go in one particular direction. You need to give them the strength to reach that particular direction rather than force what you want to do on them. Very simple example, spending quality time. So what is quality time for you might not be the same for the kid, basically. Just coming home from work and then the kid might be playing something. You'd ask the kid to stop playing and come and start spending time with you. That might not be a good idea. The kid is not interested in spending time with you then. Rather, you should be able to take a day off to go and probably see, an annual day function for your kid. You should be able to have that freedom to do that. So this is a photo which was taken in my daughter's college. It was a swimming competition. Okay, it's an inter-school swimming competition. Okay, just imagine when you were a child, you were not even good at playing probably football or hockey also, and this person has reached inter-school swimming competition. There were only 3 parents attending the inter-school combination. Can you believe it? It's your child who has reached an inter-school competition final. There were only 3 parents attending this. And out of the 3, 2 of them were my daughter's parents. That is me and my mother, me and my wife. And there was one other parent. So it was a horrible situation to see that your daughter has reached a swimming competition. You need to be there with your child at that particular time, not when you decide it's good quality time for her. You should be there when she requires you the most. How proud our daughter must have felt. Even if she came only 3rd in that swimming, she was proud that her parents were there to witness it. This was another day long back. It was around 8 years back. I was taking a class in this particular school, basically. Now, why was I doing this? Why was I leaving my, thousands and thousands which I would have earned at work, and I came to take a class for kids over here? Why? Because this is my daughter's class, and me taking a class over here is worth so much for her. Actually, it's worth much more than the thousands and thousands you will earn when you're working. It's worth more than 1 lakh or 2 lakh of rupees also, just taking 1 or 2 hours and helping them out when they actually need you. You can spend time with your family by looking at the phone. You can spend time by doing something really amazing also. So even if you go for a ride like this once in say 15 days, 20 days, the child will remember you much more than taking her or him out for dinner every alternate weekend or anything. What about family and friends? So nowadays, everybody has started socializing on Facebook, Twitter, Instagram, and think that is only socializing. Absolutely not. You are not even meeting your friends. And in fact, Facebook and Twitter will only show good achievements of your friend. You will only end up getting angry and irritated as to why you are not achieving the same thing as your family and friend. That is not a good way to socialize at all. Another good way to socialize is to meet in professional meetings where you need to dress and other things. But the better way to do is this way. Do what you enjoy. You meet your friends. This is a complete weekend that I took off from my work, which I could not have done in the corporate hospital. But here I took off a complete weekend and I called my cousins home and we just had some crazy time. We played cricket in the house. We played table tennis and we listened to music the whole day. And amazing time. 2 days I took off without having to worry about anybody. You need to get your 150 minutes per week of exercise. Remember, earning money and getting a great, property is not, you need to live healthily for yourself and for your family as well. Please ensure that you get your 150 minutes of exercise well. Hobbies and passions, well, you need to know yourself well. There may be some things where, other people don't know about you, but you know about yourself. That is called as the facade. And there may be some things where you don't know about yourself, but other people might know that you are quite talented in that. So if you're able to identify what is that facade and blind spot in your life, suddenly, you'll be able to unearth a lot of talents in you. I personally realized that I love to travel. And after going to England, I decided to watch a football match rather than looking at the history and culture of England. You see, I don't have enough time to see history and culture of India. Why I should go there? I should go and enjoy what I am doing there, is it not? So probably, trying to identify what you would like to do with your time and what you want to achieve in your significant other time is up to you, and you should be able to enjoy it at any particular time that you decide to do it. So this is me singing at a karaoke. Okay, that's one of my hobbies. Other hobbies is writing books. So I have written now 5 books, out of which 3 have become commercial successes and 2 of them are going to become movies as well. It's a totally different angle of mine, which I discovered after the age of 40, which I would have probably, not age of 40, after the age of 37, 38, which I would have probably never discovered had I continued to work in that corporate hospital and not turned into an entrepreneur and got the time into my hand. I think with that, I've given a brief message, and I hope the message is quite clear and people have taken points to see what they could do with their life to complete their circle of life. Remember, that circle of life is not an ideal circle of life. Okay, so what you want to achieve might be different for what I want to achieve. So it cannot be like, ideal circle is this only. For your circle might be different, my circle might be different. But have you achieved what you try to achieve? That's what I wanted to go. As an entrepreneur, probably you can do that better because you have your time and life in your hands rather than when you're not. That's all. Thank you.
Thank you, Dr. Santosh. A beautifully delivered lecture. Actually, you nailed it. Entrepreneur, commonly seen as an innovator, a source of new ideas, services, procedures, and business. Thank you for enlightening us, and we are happy to see and we'll move forward for the next lecture. Getting ready to start your endocrine or diabetes center. What the book don't tell you, by Dr. Shrikant Kongra. I would like to invite him here. He is a MD and DM, consultant endocrinologist at Endo Life Hospital, Guntur, Andhra Pradesh. He had done his DM endocrinology in 2006 in Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, UP. MD in Internal Medicine in 2001 in All India Institute of Medical Sciences, New Delhi. He had done his MBBS in 1998 at Guntur Medical College, Guntur, AP. He had many contributions, 14 years of experience as consultant endocrinologist, best outgoing student during MBBS with 12 gold medals, A.V. Gandhi Award for Excellence in Endocrinology, several researches, but publications in national as well as in international journals. So I would turn it over to Dr. Shrikant, who is going to lead the final lecture of this session. Dr. Shrikant.
I request the chairperson to please announce them to stay back for the discussion at the end of the session.
Yeah, please. We are after we will go over the 3 topics here. We will have to discuss and the ideas over the and questions over this session. So please stay back. Don't leave the session. Thank you. Dr. Shrikant, please.
Yeah. Am I audible? Hello? Hello?
Yes, sir. Yes, sir. You are audible. You are visible.
Yeah. So first, I would like to thank Dr. Unni Krishnan for giving this opportunity. So without wasting much of the time, I would love to go on to the top. So that is getting ready to start your endocrine or diabetic center, what the book won't tell you. So actually being doing post-graduation and super specialty from elite institutions. So after cracking the exams, we end up into these institutions. Every day we started our career as junior resident and senior resident in the respective institutions. We're all chasing throughout the day with respect to various patients and their diagnosis and their symptoms, and then how to send investigations, what investigations are right, and how to interpret and what treatment we need to start. But all throughout, the setup is also there, but you don't go into how the setup has been established, who established the setup, how the lab is running, what reagents they are purchasing, from where the machines have come, who is supplying them, what is the finances. These kind of aspects, usually we had a blind spot and we never bothered to look, and even our faculty also preferred to focus us on more of endocrine aspects rather than non-professional aspects. So
even in the corporate hospital, if the ecosystem is established, you end up into the setup as a consultant or a DNB student and out with endocrine knowledge. So what if you wanted to start a private practice in diabetology and endocrinology, and do you know the learning required to start your own center? Or you wanted to move to rural India with an intention to serve diabetes and endocrine patients in that particular area, or you wanted to start a semi-urban locality in major cities, or you wanted to start an evening clinic after your corporate or academic hours in an institution, or the case with me is I moved to a B-class city, that is Guntur, and or moved to B-class and C-class cities, and you wanted to set up your own center there. So are you ready? Are you equipped with the kind of learning and mindset and everything required to do that? Obviously not. But since I belong to Guntur, I did my MBBS from Guntur. My father and my in-laws and my brother, sister and my friends, everybody is staying in Guntur. So it's the first choice for me to come back and start my own practice here. But when I started within 2 to 3 months, I realized that there's no awareness about endocrinology in general public. There's no awareness. It's way back around 15, 16 years back. There's no awareness among general practitioners about how to refer, how to consider endocrine disease in a particular case and refer them across. No proper laboratory support for diagnosing complex endocrine problems were there. Even if the labs are available, they're suffering with poor quality, no enable accreditation. There's no concept of endocrine test understanding, like about dynamic testing, stimulation testing, then suppression testing. Or there's no endocrine surgery colleagues to help with us with the endocrine tumor surgeries. Or there's no availability of nuclear medicine department for nuclear endocrine scans, like be it differential diagnosis of Graves, or iodine therapies for Graves, or high dose therapy for thyroid cancer. No availability of DEXA scans. These are all unorganized and unavailable. So knowledge is there, but the facility and infrastructure is there. I realized that I was in a situation like a jungle where everything seems to be available, but it is not organized. The patients are haywire, they are distributed, everybody is handling everything. Diabetes is being managed by RMPs to diabetologists to physicians to everybody, surgeons. They have small protocol and they go on doing the way they like, and other endocrine diseases being symptomatically managed. So I was very frustrated with 2 to 3 months of practice, and I was thinking of only 2 options. Either you remain there just because your family is there, or you hail from this and remain as a substandard diabetologist or endocrinologist who treating patients with minimum facilities, or with no ability to do anything with complex diabetes and endocrine problems, or with no professional satisfaction, or leave this place as a professional endocrinologist and settle in an academic institution or a corporate setup. Even I tried that stint with joining a local medical college, which is around 15-20 kilometers away, started a small laboratory, but the support from the management, if it is not there, you won't be able to rise the way you have been trained to do. So then my father, who is my always behind my success, suggested, why don't you establish your tertiary care endocrine center in Guntur and Vijayawada and serve the needy endocrine patients. If you have around 1 crore population to deal with, that is Guntur and Prakasam district, there were no endocrinologists and the population is roughly around 1 crore. And there was no, the huge incidence of endocrine diseases is there. So why are you afraid, or why are you so inconfident? So then I realized, yeah, that looks like sensible idea. I'm just afraid that the setup is not there and I'm not happy. So here is the example of walking in a road which is already laid, that is an institution or a corporate setup or a medical college or something, or clear the jungle and lay a road for yourself. That is, in my own area, set up your own infrastructure, organize everything, organize all the patients, staff, equipments, infrastructure, and then you make a corporate setup, or maybe whatever, a trained professional setup of endocrinologist to be able to serve yourself the best, or the endocrine patients the best. So, but I was not trained to build an endocrine organization. So I was working on the components of endocrine ecosystem, then the mindset required as an entrepreneur, HR, and then finance, management perspective, and then infrastructure requirements, then organizational partners, and what other professional partners you need to this thing. If you start a center, will I be supported with the kind of number of patients to come to that area? all these things I was started to work on. And slowly I started whatever I can't do. Thought means you can't start a building overnight. So we started with a small OPD chamber, waiting hall, and a small laboratory, initially to start off only chemistry. But immunoassay initially outsourced, but later we realized that the quality is very compromised and I cannot success as a endocrinologist. And a small pharmacy I started. So initially, later that has also started. So then why don't, then laboratory also, the heart of endocrine practice is endocrine laboratory. It is like a stethoscope for an endocrinologist. Our quality of consulting depends significantly on our laboratory. Even the clinical reference laboratories are not trained well in delivering endocrine investigations to the best possible needs of what this thing. The dynamic testing like stimulation protocols, suppression testing protocols, and complex sample collection, transport requirement like in dry eyes, and rare investigations like ACTH, PTH, aldosterone, metanephrines, all these things, many people are not able to do that. So this is the one case which I would like to share. This you can see the date. It is just 1 month after I started my practice, that is 23rd of 4/2006. Referred by a neurologist for the diagnosis and management of metabolic bone disease, that is rickets. And I was referred with the diagnosis of working label of rickets. So I got the investigations done from the local laboratory. I got the calcium, which is normal. Phosphorus was slightly low and alkaline phosphorus was slightly high, but that is not clinching the diagnosis. Then I went ahead with another investigations from another lab. Again, this time calcium was low and phosphorus, alkaline phosphorus was normal. So X-ray shows ricketic changes and then lytic lesion, but somehow something is fishy. I thought maybe it is a tumor-induced rickets or something else. So I sent this patient to Hyderabad, a distance of 320 kilometers, just for the sake of investigations, around 14 years back. As I got the calcium levels, and the technician immediately after getting the value called me up and said that the calcium was 15. That is very high. It is an hypercalcemic emergency kind of picture. So alkaline phosphorus, here it came as 200, there it came as 2,500. Parathyroid hormone I asked him to do, and it was around more than 1,200. And we got the ultrasound done, and ultimately turned out to be a hyperparathyroidism, that is primary hyperparathyroidism with a parathyroid adenoma behind the thyroid, which was operated and removed and presenting as a rickets. This is like a professional excellence. Like this is the kind of work that I want to do. And if I have to do this kind of work, I can't send every patient to Hyderabad for 320 kilometers to get the investigation. Right away, I decided that I have to start my own lab. I can't rely on the local laboratories, and started with a small chemistry analyzer, which is a semi-automated analyzer initially. Within 6 months to 1 year, I felt that even that is also not sufficient. We went ahead with a fully automated chemistry analyzer. Another 6 months to 1 year down the line, we started with Centaur CP. That is Siemens thyroid and other endocrine hormone assay machines. Within 1 year time, we went ahead with Immolite and acquired several machines which is required for endocrine practice, like D10 for HbA1c by Biorad, cell counter for hemogram assessment, urine analyzers for urine assessment, ELISA analyzer for rare investigations like 17-hydroxyprogesterone and other anti-GAD antibodies and something like that. And for rare parameters like IGF and aldosterone and then cortisol, etc., I purchased Immolite. So these are the few these things, because everybody doesn't have to start with what I have started 15 years back. So that's why I'm just keeping some models of various capacities from 100 tests per hour to 300 tests per hour from various manufacturers. And this is one of the small mini Vidas machine. Even thyroid can be done in a semi-automated mode and in a small sample load. And this is the DEXA hologic machine, which I purchased around 10 to 11 years back because I was passionate about bone work. And with that, the initial setup of clinic and all those things were sufficient, but we were the first people to come around that place. A fellow endocrinologist of mine is also available in a nearby city, Vijayawada, by name Dr. Satish. He also became equally successful the way I am. And obviously, we are seeing around 60 to 80 patients every day. Our capacity of our facility is insufficient to handle the requirements of the patient population and the complexity of the referrals. So then we start that we should have a tertiary care endocrine center right now. And within 2 to 3 months, three years, we need to start something. So we planned ahead. We have gathered the planning people, and then long-term goals were this thing. Till now we were working alone. At the first time we had teamed up with local these things. Then we also considered starting an endocrine organization, nuclear medicine, endocrine surgery facility, bariatric surgery facility, and high dose therapy facility for nuclear medicine, nuclear endocrinology, etc. So all these things we materialized in 3 to 4 years. Two dedicated 50-bedded endocrine organizations, one in Vijayawada and one in Guntur, by the name of Endocare in Vijayawada, Endo Life in Guntur. So with two dedicated full-time endocrinologists, one in each center, one endocrine surgeon, one bariatric surgeon, one nuclear medicine, one laboratory endocrinologist who was well versed with endocrine investigations dominantly, and one diabetic foot surgeon. With this, we went ahead with that plan in mind, professional gathering and plan for this thing, and finance, and then bank loans, everything has been applied. And then we went ahead with the toughest call, that is starting a nuclear medicine, which was the most difficult job. But since I was not getting a local Andhra-based and nuclear physician, so I made my wife to pursue nuclear medicine in that particular field. Then we went ahead with purchasing gamma camera from GE company. Several hurdles were there. Even the plan approval took almost like 1 year to pass through, and it took another 1 year for starting the first scan. So identifying people and all those things. So ultimately we ended up with initially we started with a single head gamma camera, later a double head gamma camera. Now, with the availability of so much of nuclear medicine scans, our endocrine practice, initial days, first 6 to 7 years, our 70 to 80% of the practice was more of endocrinology rather than diabetology. So in that place, somehow we became very successful as endocrinologists rather than diabetologists. So having these investigations helped us a lot in pursuing our professional goals to the highest standards from where we got trained. So then the facility needs higher speed and higher throughput and less errors. Then we went ahead with higher standard machines like E411 from Roche and C311 from Roche and other machines. This is the laboratory, which is a Glands, with a pneumatic transport in our setup, where the sample is transported by air within 2 minutes to the lab simultaneously. It's an ongoing thing, and then separated in the centrifuges, then barcoded here, then hematology analyzer here, then D10 here. And then this is the Centaur XP, which is a high-end, high-throughput immunoassay analyzer. Then the C311 for chemistry analysis, E411 from Roche for hematology immunoassay analyzers. So this is the latestly, we have replaced both chemistry and immunoassay systems with high-throughput system of 1,000 tests per hour. Roche 600 is an automated system. Within 1 hour, any number of parameters you can do within 1 hour. And subsequently, other parameters like bias tissue, other investigations like bias thermometer, ankle-Beckel index, complication screening with fundus photography, with the Trinetra, all those things we have started. And this is a brief glimpse of video of the facility, which is around 20,000 square feet in size. And this is the reception with full of patients in the diagnostic area and billing area and OPD waiting area, and the nursing and vitals station. And there is the consulting chamber with where the patients will be seen, and then paramedical support. There is the first floor where complication screening setup and complication these things were available. Then fundus lab, which is this thing. Then clinical trials area. We also have clinical trials, this thing for global phase 3 clinical trials. This is having data recording and all, HR, and then sample processing and this thing, ECG, ultrasound machine for thyroid ultrasound and others. And non-professional, this thing, central pharmacy. Conference hall, where we train our staff as well as the patient for diabetic education programs. This is the inpatient facility with 30 to 40 beds in that floor. There is the ICU facility with 6 beds. This is the major OT. And this is the minor OT where diabetic foot and other infective OT cases were handled. With this, a brief glimpse of the facility. And then we went ahead with NABL and NABH accreditation, which was a very tough policy because somebody will judge you from outside, and even they uncover your blind spots and improve your hospital and laboratory facility to higher standards. For all parameters, we were doing quality control, NABL trained technicians and biochemists, thorough audit process. Almost it is 8 years till now that we got NABL accreditation. And quality control manager, logistic manager, everything has been done. Initially, we were focusing more on quality, but as the number of samples were increasing, the pre-analytical errors, labeling errors, processing errors, all those things are increased. Then we went ahead with completely automated laboratory with barcode generation. Lot of steps in sample mixing has been simplified, and it is now logistically so well organized that if you stick a label and put on the machine, the reports will be generated to the patient's WhatsApp within 1 hour time. So such is the automation which have included into our laboratory interface system, information system. Because of the COVID pandemic, we also added RT-PCR to our setup, with which future we can do molecular endocrinology parameters also. Rare parameters like FGF23 we are doing in-house, PTH, 125-dihydroxyvitamin D, 25-dihydroxyvitamin D, and even growth hormone, IGF-1, 17-H, everything. Whatever you need in conventional highest end research level endocrine practice, we started. For clinical trials, we had to start an ethics committee, which we have started around 6 years back. All necessary requirements were met. And now we are participating in global phase 3 developments like semaglutide trials with respect to outcome, like flow, focus, pioneer teens, pioneer plus, and scale, sustain. Several trials we have been a part of them, and with the development of the new molecules. And with the time, we wanted to go advanced with respect to academics in endocrinology, like TNB program, training endocrinologists, and then research in our own community, like Indianized research and localized research, and then preventive community screening, preventive endocrinology, like subspecialty practice, like pediatric endocrinology, thyroid clinic, obesity clinic, type 1 clinic, whatever, bone clinic, etc. And then develop the team to higher standards. When I look back, I realized that there's a lot of phases. So every phase, initially we started with 10 to 20 patients. Over the years, in the 15 years, now as institutions in both places to put together, we see around 200 to 250 patients every day are dedicated all sorts of endocrine cases with multiple team members. Every phase, the challenges with respect to delivering the endocrine care are totally different. We were continuously evolving throughout these 15 years, and we have a lot to achieve further, and we need to improvise even further. So how do you plan? If you want me to give a small suggestion, so choose the place of practice very wisely. For me, it is a natural choice because my family and everybody was available locally. But I have seen my friends once settled in a suburban area of Hyderabad, seeing around 20 to 30 patients every day. But the same person settled in a place like Warangal, Nizamabad, Guntur, Vijayawada, Kadapa are seeing around 80 to 100 patients every day. There, the population to cater is big. The success is very this thing. You are the first person to start off with endocrinology, and also choose the clinic very properly, because you can't plan a bigger setup in a smaller place and you vice versa. So decide what facilities do you need. For us, there was nothing available, so we had to do a lot of work in setting up everything. What if there is a nearby local NABL accredited lab available? So talk with the biochemist and establish whatever is needs you are having, and then take a good association with them and MOU with them, and then enjoy the best laboratory facilities. And if a nuclear physician is in, talk with the nuclear physician, tell them what you need, and then get what you need. And if endocrine surgery colleague is available, he can freelance and come and do the surgery at your premises, or you can send to him and then get the things done. So that way you can work out what is the plug-in and plug-out kind of models, and then do that. If you decide what professional needs you need, there are several needs. As in the previous lectures, it has been highlighted well: dietitians, lab technicians, optometrists, podiatrists, ultrasound technicians, ECG technicians, phlebotomists, everything you can. Apart from that, non-professional staff like billing, receptionists, everybody needs a lot of training. So ultimately, at the end, my message is more endocrine centers, more diabetics are needed in India. The only way is increase the lives of diabetes and endocrine patients. Understand your priorities, imperfections, blind spots, finances, limitations, your own limitations, be it financial limitations, time limitations, family limitations, and choose the place of practice very wisely. Go to an area where nobody is available. And many people think that I will miss this thing, but definitely you will professionally be very happy and balanced in life. Develop your vision for your center, work for it, invest in it, keep your brain, heart, and soul into it, and try for continuous improvement program for your ecosystem and individualize the needs and make a plan. Just don't copy a center which has already been successful. There are several hidden factors in success of that particular center. Go slow and go strong and go continuously. It's a very successful thing which I would like to suggest. Thank you. With which I would like to end my talk. Thank you.
Thank you, Dr. Shrikant sir. You actually guide us how to build endocrine and diabetes center. And this is definitely, book won't tell you the strength of any strategy is in its implementation unless all teammates are on the same page. So no one can succeed in the market. Thank you so much for your guidance. So we can look forward for the discussion. I would like to invite Dr. Suresh Jain sir and Dr. Santosh sir for the questions and answer session. So these are a few questions. First question is for Dr. Sunil Jain sir. Sir, by Dr. Dattatreya Indurikar, he is asking, sir, can an MBBS doctor interested in diabetes care can run diabetes clinic with her dietitian spouse?
So, see, as such, a MBBS doctor who is trained in the field of diabetes, then there are two aspects of this thing. Doing a practice on diabetes with a dietitian as a spouse, obviously they can work. But degree aside, they should have some good training in the field of diabetes. Good if they can do some certification, some kind of these things, that will be an add-on. So if they go by this thing, then that will be a better way of doing practice. Though if we strictly talk in a legal sense, then there are a few things here that ideally speaking, if we say ourselves as a endocrinologist or a diabetes specialist, then we should have a qualification like that. Now, having said that, when we want to do a good diabetes practice, obviously we should have a good knowledge of the subject, but looking to these kind of requirements, good if they can do some kind of training, certification, and then establish at say as a diabetes expert, then that will be better. That is what my suggestion will be.
Yes, thank you, sir. I seen Dr. Unni Krishnan sir here. Welcome, sir, and thank you so much for the knowledge piece. What's your opinion on this, sir?
So I feel that, if you look at it very legally, it's an endocrinologist who should be managing diabetes and diabetes centers. Having said that, there are 76, 77 million people with diabetes in India. And I think it's good for every physician and internist to have a developed knowledge about diabetes. And if they can take care of diabetes patients systematically within their own practice, supposing there is a physician who's seeing tuberculosis, gastrointestinal disorders, infections, diarrhea, and he finds he has a lot of diabetes patients. If he wants to take care of them in a systematic manner, calling them on a particular day in his OPD, his or her OPD, and systematically screening them, I think that sort of development within a clinic is good for patients to have. But very legally speaking, I think these practice should be set up with a legal angle in mind. Definitely, if you look at all the nutritional, there are a lot of companies promising remission of diabetes, reversal of diabetes. Any day, MBBS doctor with a nutritionist along with them is better than many of the so-called tech companies making huge promises or fad diets, etc., etc. But yes, from a legal standpoint, it is important to have a degree. May I also ask Dr. Santosh about a different topic, because you are not just a doctor, you have built a business of scale, and you are also an author. In fact, your book is just out. Book number 5, been there before. It's available on Amazon. Amazing. How do you do this? How do you find time for this?
So yeah, in my talk, I had mentioned that, there is a certain aspect of your life that's called as the blind spot, actually. So when you're working and you're studying hard, and then you get into a rut in working in a corporate hospital, and you're working for 9 to 10 hours, you probably don't realize some things about yourself. When suddenly a little bit of time gets freed up for you, you will realize that there are so many things that are different from than just being a doctor in your own life. So I enjoyed what I do. And my wife probably sleeps 1 hour more than I do. That's where I gain 1 hour of my 1 hour extra in my life to, write these books and get them published. So with all the blessings, I think 2 of my books are now going to soon come on the screen as well. Thank you.
Thank you, Dr. Santosh. You actually guide us about the bird story, which is very influential.
Yes.
And yes, light kite will fly high. He actually set the example. Thank you, sir. So we can conclude the session here.
I have a question for Dr.
Yes,
Kalra, because it's not it's I have worked throughout my life in a big city. Dr. Jain is also in Indore, which is a big city. Hyderabad, Dr. Santosh Ramakrishnan, of course, originally is from Pune, but now he's in Hyderabad, and he's also. But why I really admire. I want to learn from Dr. Srikanth is in Guntur, he set up where there's not even hormone testing available. He set up a lab. It would have been so easy for him to go to a big city and join a big hospital and become an endocrinologist there. So I think he has got lots of entrepreneurial streak. And where did that gene come from? Are you in a business family, or how did that come to you, that thought? Because it's not very common to see this.
Actually, my parents were doing private practice, and my family is full of doctors, like 7 doctors in my family, and in-laws family also 7 doctors. So at least we know something about private practice. So, but that is not what is motivating me to this thing. So as I said, for 30 years, there's nothing but endocrinology in your mind, life, everything. We lived with that. So after coming here, when I'm doing substandard endocrine practices, you're not yourself. So you have made so much possessive about your endocrinology. So whatever I was doing, whatever I was gaining, I was continuously investing continually on endocrinology only. So it is not profit and loss and all those things. And I did have lot of losses and everything. But the only thing which was very successful was settling in a place like Guntur. There was no competition, and we didn't have to work for any competition, marketing, or something. Just be yourself, do your best. The best marketing was done by the patients. The patients were going on to the rural villages and then going on sending the patients by this thing. At that time, the thyroid test used to take 3 days by sending to Thyrocare and all. And 3 days it used to take the report. And the patient will say, if we go there, within 3 hours, the report of thyroid is given, and you don't have to travel twice, and those kind of invisible marketing done by the patients itself. Even today, we don't do market. Only thing is, be yourself in the best version of yourself in endocrinology. And simultaneously, as Santosh is saying, I also follow that kind of philosophy. In 2010 and 12, I also had that kind of crisis. Then I had looked towards the philosophy books and then management books, and I have been for almost 3-4 years. I was going to read all those books, and even I attended some workshop in transformational leadership in healthcare management in some ISB and all those business schools. So then I realized that every doctor who wanted to set up his own clinic, he needs, obviously, if he's a successful doctor, he'll be seeing around 50 to 100 patients. So apart from the professional needs, everybody will have managerial needs. Like that setup needs to be managed, appointments needs to be managed, so much of managerial, and that science is already existing. but it is there in somewhere else. It is in the business management literature, or it is somewhere else. And the entire curriculum, you are filling your mind with so much of endocrine knowledge, but you have even just like this. You may be very intelligent, but if you go to France, you can't speak French because that language itself is not known. The same thing happens with many doctors. That management language itself is this thing. Ever since I started looking that particular area after uncovering the blind spot, for our smartness, it is not difficult to understand. Once we are into the every aspect of management, we started excelling in everything and hiring help from different fields to improvise the knowledge. Now we are balanced professionally, managerially, in life also, work-life balance. I follow whatever Santosh is saying, but it is maybe midlife will give that kind of jolt. Unless you crack that and go forward, you can't go forward balancedly. That's the story. Thank you.
And of course, the leader of all of us is Dr. Sunil M Jain, because he started the big center and in Indore. Sir, what do you do in your spare time and your hobbies? We've heard Dr. Santosh and Dr. Srikanth talk about it. And I visited your center, and also your interest in training doctors in diabetes. What were your thoughts when you started a training program for MD physicians? Because I think that, with 76 million people with diabetes, I think there is a need for MBBS doctors, MD doctors, everybody to get trained in diabetes. How did you think, and how did you develop that training program, and why did you develop that training program for diabetes?
So, Dr. Unni, what has happened, I came to Indore in 1995 after doing my DM from Chandigarh. And after, say, about 10 years of clinical practice, I realized that there are very simple practical tips and gaps, which are unfortunately missing. And since during my MBBS days also, even in my medical college, I was known for good teaching. In fact, when I was doing a house job or final professional, I used to teach my MD residents. It was reverse, other way around. All our MD doctors used to give me topics that, okay, read this and teach us prior to exam, that kind of thing. That means there was somehow a skill there of teaching and communication. And after 5-10 years, I realized, let me utilize that. And that's how my training programs started. And by now, more than 3,500 MD physicians have been to Indore for various our training activity. And apart from this, one big interest area of mine is to develop the technology solutions to make the patient communication easy. And that is the area where I am working since last 20 years. And sooner or later, we have developed now the technologies through which other doctors also can utilize, and they can communicate, contact, and make their work very easy with the patients also. That is the time management area. So these are the few things which are my interest areas.
I know that in your hospital in Indore, your dietitians have a special app and a special software for people who are on basal insulin or on basal bolus or premix insulin. Can you tell us more, and can other doctors also, purchase the app and, use it in their clinics? Because I think this sort of a dietary app is very useful for all nutritionists and doctors, because, dietitians always give the diet prescription, but if they have a software to tailor it according to the insulin regimen, that will be very interesting.
Yeah, that's what happened after when I entered into practice and so many newer insulin preparations started coming up. Then I realized that the diet management is going on a very standard way, while we are treating with exogenous insulin whose pharmacokinetics is entirely different. So we need to have different kind of calorie distribution protocols. And that's what we developed. And now it has reached to a stage that many pharmaceutical companies have taken the interest, and most likely in next 2 to 3 months, it will start reaching to the doctors. And these technology for the patients of the doctor will look as if the doctor have developed for that. So what we are trying to keep in mind, that the doctor who is working on the technology should be considered as the main person, is the key person, not like any technology company who is giving an app and people are downloading. So when we are going to collect the information from each and every doctor about their details of their clinic, and we have done a system by which when the patient will reach to that clinic, they will do few things, and now the app will behave as if the doctor have developed. And through that technology, they will be able to transfer a lot of information, including the diet based on the insulin regimens.
It's been really wonderful listening to all three of you. And as I said, if I think about endocrine centers, diabetes centers, and how a center can develop in a rural, semi-rural district of India, I think of Dr. Srikanth. And I think of how in the heart of India, the heartland of India, a diabetes endocrine institute like Total has sprung up. I think of Dr. Jain. And when I think of a full-fledged diabetes clinic, which can be replicated in many cities with service and that sort of scalability, I think of Dr. Santosh. If there was a Shark Tank episode on diabetes, I think you three people will be the sharks, if they are the big sharks in such an episode. So thank you all for this very thrilling section. And before we go on to Dr. Karthik, I'd like to Dr. Deepanjali Pawar to speak a few words also at the close of the session.
Just 1 second, Unni. Thank you very much for this opportunity, and let me know a little more about Srikanth and Santosh as well. Thank you.
Thank you, Dr. Unni Krishnan, sir. Thank you, Dr. Sunil, sir, Dr. Srikanth, and Santosh. Very, very healthy and beautiful session this is. I never thought about the entrepreneurship in diabetes and how they told us, how enlightened all of the three beautiful lecturers to us. Thank you, sir, and wish you all the, I have to sum up here, and thank you so much for the session. Thank you for giving me an opportunity to chair this session, sir. Thank you.
Thank you. Thank you, everyone.
Thank you. Thanks a lot. Have a great evening.
And back to the organizers.
Yeah, thank you.
Very much for a very interesting and enterprising talk. I thank all the speakers and chairperson of the previous session. Now we move on to the next session of this summit. It is titled Networking and Technology in Diabetes. It is titled Networking and Technology in Diabetes Care. And I have the pleasure of inviting the chairperson, Dr. Shweta Deshmukh, who's there with me. She has done her MBBS and MD medicine, and she's currently with us over here at Chelaram Diabetes and Multi-Speciality Hospital. She's a consultant physician and diabetologist. She's also done a fellowship in rheumatology from the Dr. D.Y. Patil University, Pune. She has got an advanced certificate course in prevention and management of diabetes and cardiovascular disease from PHFI, Pune. She's worked as ICU senior registrar in Dinanath Mangeshkar Hospital, Pune. She has also been an ex-assistant professor at the Symbiosis Women's Medical College, Lavale, Pune. And she's also been an ex-senior resident at Dr. D.Y. Patil Medical College Hospital, Pimpri, Pune. Welcome, madam. And
thank you so much, ma'am, for very warm welcome.
I also have the pleasure of inviting Dr. Pushkar Kher, our chairman for the next session. He has done his MBBS and DNB in general medicine. He has been a vice president in life science and healthcare businesses and chief of digital healthcare at Ethos Digital. He's been a practitioner in communication excellence through neuro-linguistic programming, certificate holder in the foundations of design and thinking from IDEO, empaneled reviewer for project proposals in biotechnology and healthcare digital innovations for BIRAC. A warm welcome to both of you, and over to you for the next session.
Thank you so much, ma'am.
Thank you, ma'am. I'd like to welcome Dr. Karthik Bhalchandra to talk on a very interesting topic, that is strategic use of social media, advice from a doctor. Dr. Karthik has completed of Endocrinology, Sri Ramachandra Medical College, Chennai, 22 publications in national and international journals, blogs at medicalruminations.wordpress.com, is a hobbyist programmer and data science enthusiast. Over to you, sir. We can start the session.
Yeah. Thank you. Thank you for that kind introduction. At the outset, I would and especially Unni Krishnan sir for this wonderful opportunity to talk on a fairly offbeat topic. And I sort of like offbeat topics more than the usual endocrine topics as such. So today we'll be discussing about social media for doctors. This is not going to be a to Z, cradle to grave, everything we need to know about every platform out there. But the idea of this talk is to basically instill a sense of a framework for thinking about social media and how best to use it for whatever we want to achieve. So the first question before starting any major thing is to ask why. Why social media at all? Why use social media at all? So less than 40% of the global Fortune 500 company CEOs actually have some social media, which means majority of them don't. So what is it that is it an asset or is it a liability for us? Is it something that wastes time or is it something that brings some value to us? Now, at this point, we must realize that whether it is an asset or liability is not an inherent property of the social media itself, but rather it's a tool and if it is a liability to us. Now, there's a common tendency for us to look at social media as something that is a fun thing to use to spend some time, while away time. But those who have made social media as a funnel to bigger things basically use it for work. And just like we take our work seriously, we wouldn't be messing around with hormones just like that. The same way, social media, when used for work or as a tool in the pursuit of business goals, is a very different beast and therefore requires careful thinking and careful strategy. And which is why we are here to discuss that. Now, this is the single most important slide in the entire presentation. So I want you to pay some attention for a couple of minutes to this. We'll be repeating it again and again so that you get the idea right. Now, what we want to do is our goals. Then the goals will determine what kind of content we create. The content will be apt for certain kinds of channels. And those channels, whether at the end of the story, we will measure some metrics to see if we are achieving those goals or not. This is how the social media marketing pipeline works, regardless of the channel, whether it is WhatsApp or Facebook or TikTok or LinkedIn or whatever be the thing. All of this will work through the same pipeline. And pushing from one end of the pipeline to another end of the pipeline requires certain resources. The resources can be your time, can be your talent, it can be money, can be manpower, anything. But some resources are needed. Depending on our resources, we'll be moving from one segment to next: goals, content, channel, and measures. Now, goals are things that we want to achieve. And in order to achieve something, we must at least know what we want to achieve. Therefore, a goal needs to have certain principles behind it, and those are encapsulated in the form of SMART. And there is the primary reason why we use social media. That's what goals are. Some of these goals would need to be refined, but these are usual starting points for why a doctor might use social media. One is to humanize your web presence. That makes you more likable, more approachable to patients or friends or whatever. That's the humanizing your web presence one. That's the overarching goal for many doctors. Second is to create a funnel for leads. To be honest, it sounds like a business presentation, but that is because whether we like it or not, healthcare is indeed a business. It's just an ethical business, nevertheless, but it is indeed a business. And therefore, some of the lingo that sticks with business presentations have somehow carried on to this one too. The third is thought leadership. Whether people look up to you for leadership or not, that can be developed by strategic social media presence. The fourth is personal branding. What comes to mind when people think of when they look at your social media profile, or in general as a person, what one word comes to their mind? That's called personal branding. Then the next is developing your own tribe of people who are interested in a certain specific area, maybe across the continents. You can develop a tribe with social media. And finally, you can use social media to learn something as well. It's not always giving, but it's also getting from the social media. Now, you have to carefully think about what exactly you want to get from your usage of social media. Otherwise, what happens is we just spend some time there. It gets wasted here and there. Spraying our efforts all over the place will only lead to loss of uh, energy and loss of time and efforts, and that will not fetch us the goals that we want to get. Now, the goals that we have must be strategic, measurable, achievable, realistic, and time based. Now, these are the SMART goals. Probably all of us have heard of these SMART goals, but in the context of social media, you must have something in mind. It need not be very precise, but at least something like, I need to increase my blog readership by 20% by December 31st, something like that. You have a specific goal by a specific time period, and that is what you want to achieve by using social media. So you may have to write down your goals, but in this context, I showed you some starting points from thought leadership to personal branding to getting more leads to all sorts of things. But it is wise to keep one, two, or at the most three goals for your social media presence, for each account at least. The reason is that if you have 7 or 8 goals, it means that you're not really clear what you want, and therefore they don't become goals, they're just wishful thinking. A goal is specific and it needs to be achievable and measured. And for that, we can't have more than 2, 3 goals. Now that we have set our goals, let's say we want to get these many followers or this increase in blog readership or something over a period of time. The next thing is to see how to go about achieving that goal. The next thing after goals is content. Now, like any other part of the internet, content is king when it comes to social media. There's no social media without content. Now, which is why at the end of the day, you need to ask yourself a very important question. Are you a net content creator or a content consumer? A creator is someone who can disseminate that content across any number of channels, 15 channels if you want to. But a consumer is simply sitting on the sidelines, and basically at best he can achieve is learn something from those who create content. Now, content consumer is the lowest of the hierarchy, and that is something we do not want to be in. And therefore, either we need to become a creator ourselves or we need to hire someone to create some content for us. Either one of these two things is absolutely must if you are going to use strategically the social media to improve your web presence. Now, what kind of content do we create? Each of us have certain strengths, some weaknesses, maybe specific opportunities for us, and perhaps threats. The threats part are probably not very relevant to doctors, but strengths and weaknesses are certainly relevant. For instance, I tend to write more, and therefore textual content creation would be my strength. I'm not really good at singing or making some funny videos, and therefore that might not be my strength. So you need to know yourself first, what your strengths are, and you need to align your strengths to the strengths of the different channels of communication out there. There are many different kinds of social media, from the mother of all social media, Facebook, to Twitter, to even niche ones like Gab or Quora or anything like that. So depending on what is your strength, you create content, and that content should be native to the platform in which it is served. So what kind of content do you create? Let's say you are good at creating textual content, that is write-ups. So you need to anchor your content to certain pillars, maybe 3 or 4 pillars, so that you're not doing all over the place and you just remain focused. So for example, this is an example of a content pillar for an endocrinologist. Maybe he tweets about endocrinology 50% of the time, diabetes 20% of the time, medicine, random issues in medicine, from government things to all sorts of interesting stuff related to medicine, sometimes to advocacy, and sometimes he might give some tools and tips. So this is the overall map or content map of his social media presence, regardless of which channel we are talking about. We're not even into channels yet. So we realize that content creation is important, that content creation should mirror our own strengths. And just because writing is your strength doesn't mean you write anything about American politics to, geography of Russia to all sorts of things. You need to restrain it to certain content pillars, and the number of content pillars should not be more than 3 to 5 at the maximum. Then what kinds of content are there? I talked about textual content, which is what is easy for most people. The next is producing images and video. These are the three primary types of content out there. If you're good at producing textual content, you need to put it in a channel that is good for textual content. For instance, Facebook, LinkedIn, or specific blogs like Substack or Medium or your own blog. So textual content has many different options, and you need to put it in the appropriate channel for it to work. Next kind of content is images. It can be some cheesy images of your family or friends, but those are not the things that we are talking about. What we are talking about are images that are designed to basically enhance the chances that you achieve whatever goal you have set to achieve. Maybe you want to make your clinic famous in the area. So that is the kind of image that we are talking about. Creating that kind of image is much more difficult than simply clicking a selfie of you with your friends. So that is the kind of image that we are talking about. One common image channel is Instagram. Videos are the mother of all content because they engage so many senses. It's easy to watch and they have the highest engagement, but they're also the most difficult kind of content to create. So you can, stream those images in YouTube, Instagram, or Facebook, or any of these profiles. But ideal channels would be YouTube and Instagram. The idea behind separating out these content types is to ensure that the content must be native to the channel. So what people want to do in that channel, it should align with the content that you create. Nobody comes to LinkedIn to watch cat videos. So therefore, LinkedIn is a sort of sober, very serious platform. And if you go there and make some funny videos, it may not really click well. Similarly, Instagram has a vibe of its own, same with Facebook and so on. So the content that we create must be channel native. There are plenty of resources out there. Textual content, you need to create it yourself. There's no point in simply copy pasting or sharing other people's content. That way you do not develop a personal brand or for your clinic or hospital. Images, many stock images platforms are out there. With little bit of tweaking, you will be able to brand your content onto that image layer. So Canva, FreePic, and Pixart are some of the common platforms that are useful for creating image-related content. Again, video content, basically you need to create it yourself or let some professionals do it for you. But ultimately, you need to use certain resources to create each of these content. So once you create a content, that's not, you don't simply go and see the platform alone, but you're also very concerned about what kind of audience you want to reach. If you want to reach 30 to 50-year-old males, the kind of content you create would be very different from trying to reach 15-year-old girls. So audience persona, you don't need to formally write down a piece of paper, but at least in your mind, you need to have, this is the content I am creating, this is the channel I am feeding it to, and this is the audience that I want to reach. Once you are clear in your mind, only then you sit up and write your first word. Otherwise, what happens is it's just a little mushy and it's not really focused enough. So who are you trying to reach? Now the next question is, if you want to catch the fish, obviously you should go where the fish are. There's no point in putting the the hook in some random place. You need to know where the fish are. So different kinds of social media have different kinds of users. Instagram is famous with mostly teen to youngish crowd who are hit. LinkedIn is more with the recruiters and professionals. Facebook is for literally everyone, but again, there's lots of people out there, so different kinds of content will be there. So, who are you trying to reach? And depending on that, you need to choose the channel. And we have talked about resources, different ways to create content, but you should also have some budget if you are doing it on a professional basis for content creation, dissemination through these various channels. Sometimes you can run paid ads or things like that, and you can use tools to create or monitor the content or pay people who do that for you. So this is a budget that you might have in mind. It does not matter if you have a zero budget. So I don't do any budgeted content, but if you're doing it on a large scale, this is something you might need to think about. What kind of resources you have and how you use those resources. It doesn't matter if you have zero budget. There is basically a strategy for every budget out there. And then once you create the content, you are now interested in seeding the content. The whole point of having a network is that you're trying to reach someone that you do not know. If you're going to only send it to your wife or your girlfriend or whatever, some person that is known to you, you don't need a social media at all. You can simply email them or put it in some WhatsApp group. The idea of a hashtag is to reach people who would otherwise not be able to see your content because they don't know you, but they know the thing that they are searching for, which is the hashtag. And hashtags have also been used to create a tribe of people who are basically interested in specific things, like, for example, Alzheimer's disease. So, patients with Alzheimer's disease, doctors who are treating Alzheimer's disease would also be using hashtags related to that. And by that, you will be able to, meet new people, even form collaborations with them. But at the end of the day, there's a lot of people who overdo the hashtags, hashtag X, hashtag Y, hashtag Z, and so on and so forth. It becomes a kind of hashtag vomit. That whole content thing looks like a hashtag vomit. Don't do hashtag vomit. Don't overdo it. Just put a few, one or maybe 3 to 5 hashtags, so that you don't look like simply craving for attention, right? Now, we till now whatever we have talked about basically is simply marketing at the end of the day. And awareness is whatever kind of awareness that you create is at the end of the day a marketing campaign that is that is used to skirt around the rules of NMC or MCA that says doctors shouldn't be marketing themselves. That is a different kind of thinking, whether you philosophically agree with it or not. Awareness things are basically ads, and whatever kind of ads that you want to create will be created as an awareness. Once you have a content, have the audience right, and then everything is created, you need to think about frequency of the seeding of the content. So maybe you want to post every week or every 3 days. So it should be fixed in your mind, and that it should not be too infrequent also. If you post once a month, because the platform itself is crowded, there's no chance of traction if you're posting any less frequently than once a week. So most posts should be planned, and you might even use an editorial calendar such as this. So this is an example of an editorial calendar. I will post this kind of content on Facebook on this Monday and on Wednesday, something like that. You could even devote 2 hours of your time per week for social media marketing, whatever you're doing, right? You can automate the process with many different apps. Buffer is the most famous of these. Our own Indian Zoho Social is there. That is again an Indian app which automates the editorial calendar from content to the audience. So there are many different apps out there. You can just Googling it will give you an option. And finally, once you have created the content and then seeded it through different channels from Facebook to Twitter to LinkedIn, you need to have certain measures of how well your content is doing. For instance, this is the Twitter analytics page I took yesterday, simply a screenshot of my Twitter analytics page. It turns out that the tweets have reached 411,000 people in the last 28 days. That is the actual reach of social media. You could reach 4 lakh people even when you are creating relatively minimum content over a period of 3 days. I don't use any professionals. I don't even buy any software to do this. It's simple with average phone, that's all. So this is the power of social media. You'll be able to reach a lot of people in a very short period of time. And each platform that you use, from LinkedIn to Twitter to all sorts of platforms, have their own native analytics tools, but there are also paid analytics tools and third-party analytics tools which you can look at, and they give additional information about how well your content is doing. And based on the feedback from that content, then you need to go back to the drawing table, ask yourselves what your goals are and how well your content is meeting those goals, and then you need to refine the process over and over and over again until you reach where you want to reach. At this point, there's a bit of caution. Tycoons of social media are just tobacco farmers in t-shirts. Whatever the platform that they have, it's not an unadulterated good. It has a lot of downsides as well. And checking your likes is the new smoking. So it is always important that we understand that our job is not primarily sitting on Facebook or Twitter and doing something, but this should be a nice distraction, but not we shouldn't be overdoing. That's the important message that I want to give. So which brings us back to the pipeline. So in order to strategically use social media, first and foremost thing is to define your goals. You cannot get what you want unless you are specific about it. It reminds me of an old story of a man who asked God for the best drink and the best woman in the world, and he got tender coconut and Mother Teresa. So you need to know exactly what you want, and then you can create content, and then you share that content on different channels. Then you stick to a certain kind of frequency, know your audience, who you want to reach, and the audience who use these channels should be reached. If you want to reach young people, you may need to use Instagram. If you want to reach senior management people, you may need to use LinkedIn. If you want to reach a wide variety of audience, maybe Facebook is your best lead, and so on. So ultimately, the kind of content you create will depend on your goals, your audience, and the channels that you use. And at each stage, resources from tools to manpower to time, some kind of resource will be needed, and you need to be clear about what resources you are willing to spend on social media, including time. How much time are you willing to spend per week? If you do not put this thing in your mind, you might randomly use Facebook and Twitter and waste time around it, and that will not bring any useful things back. So ultimately, you need to measure how well your content is doing, and depending on that measure, refine the process so that things get easier for you. So that brings us to the end of the presentation. If you had listened this far, you might probably think that this whole thing is something formulaic, that you have some goals, then you create content, see that content, measure how well it does, refine, and so on. But it's not just a formula. If it's going to be just a formula, anybody can implement it. Even a computer can do it. But why do some things get viral and why do some people get more out of social media than others? Is because some people are authentic. That is, they are willing to be vulnerable, share their real self, while others simply copy paste or just put some standard stock images and expect to be taken serious. The fact is that at the end of the day, the most important asset that you have is you, and be authentic. And that is the single most important thing that I want to convey from this presentation. Thank you so much for listening. And I once again thank Telaram team and Unni Krishnan sir for this wonderful opportunity. Thank you so much.
Thank you so much, Dr. Karthik, for enlightening us different platforms of social media, how we can use it for our benefit. Please stay back for the discussion. We'll get back to you. Now, I'll request Dr. Pushkar would you like to introduce Dr. Sanjay Kalra for the next topic?
Yes, thank you. It's an honor and privilege for me to introduce Dr. Sanjay Kalra for an important topic of the power of networking explained. He actually needs no introduction, but for the formality, he's a DM in endocrinology from the prestigious AIIMS New Delhi. He's consulted at Bharti Hospital, Karnal, He's the president of the Endocrine Society of India. He's the vice president of the South Asian Federation of Endocrine Societies. He's a education editor for the International Society of Endocrinology, and he's the section editor for the Endocrinology API textbook of medicine. It's going to be my curiosity to hear and listen to Dr. Kalra on the important topic of the power of networking explained. Welcome, Dr. Kalra.
Friends, it's a great feeling for me, a very pleasant feeling actually, to be able to network with you today. And while we take this opportunity to network with each other, professionals from across the country, across the globe, let's spend a few minutes talking about the beauty of networking. Now, the beauty of networking is that it is natural. And this ancient Indian wisdom tells us that 1 + 1 is not equal to 2, it is equal to 11. And that is how networking grows naturally. It grows with compounded interest, even more than that. Once you begin networking, you begin to enjoy the beauties of this phenomenon, and you begin to grow from strength to strength. Many of us will say, this talk is not for me. I am an introvert. I do not like networking. Then I would humbly like to submit, no one can be a greater introvert than me. And there's nothing wrong in being an introvert or in being an extrovert. Irrespective of what kind of brain, what kind of cognition, what kind of psychology you bring to this world, you are part of a network. You are part of a network of Homo sapiens sapiens. It comes naturally to you. So irrespective of what kind of background we are from, what kind of processes we follow, what kind of phases we are going through in life, this is the topic for you. This is the most important 15 or 20 minutes for you in the Chelaram Diabetes Institute conference. Why is networking important? Networking is important. And even when you look at the human body, you see that networks are in place. The networks can be neurological. We'll talk about them sometime later. They can be exocrine. The pancreas, for example, secreting its glandular secretions so that digestion occurs. That's exocrine. But beyond that, we have the real networking of the body, and that comes from the endocrine system. Some networks are autocrine, limited to the cell itself. They do have their role in life, but offhand now, can you think of any autocrine glands? Can you think of any autocrine hormones? Yes, but you would have to think for a few minutes. So if you remain limited to yourself, you will certainly become a strong individual, but your relevance, the meaningfulness of life will be limited to you. Let's move one step ahead. And we have paracrine glands. Now, paracrine means that you have a glandular substance which influences the cells nearby. More meaning to the life of that cell. More meaning to the life of the cells that surround it. So if we are a paracrine individual, that means, of course, we will take care of ourselves. Maybe we'll take care of our family, our close friends, and our influence, our circle of influence will be limited to them, to family and friends. That's good. But we are in an endocrine conference today, in a diabetes conference. So what does the endocrine system do? Small glands, some weighing milligrams, some weighing even less than that. Some of the heaviest glands in the body would be maybe the thyroid at 25 grams. But see the weight of the punch that they pack. Tiny glands like the hypothalamus, the pituitary, the adrenal, the beta cells, all weighing just half to 1 to 2 to 4 grams. They are able to influence the entire human body, the entire 100 kg. That is what the endocrine system does. And it does it through networking. And that is what we should do if we are to find meaning and purpose in life. I am just a mere individual,
But if I become part of a network, then I can influence, I can help the lives of so many people around me. That is the beauty of networking. If we accept that, then let's think more about endocrinology. How do the endocrine hormones, how do the hormones interact with each other? How do they network? Now, usually there is negative feedback. Negative feedback means the pituitary secretes, let us say, ACTH or TSH. But when the pituitary senses that there is a very high level of cortisol or a high level of T3 and T4, then a negative feedback goes and the pituitary reduces its secretion. If that negative feedback is missing, let us say there is no cortisol, maybe there is no T3, no T4, or the levels are low, then the pituitary upscales its secretion and we get more ACTH, more TSH. This is negative feedback. But in the human body, there is positive feedback as well. There are 3 examples of positive feedback that come to my mind. And these are what we will use in order to inspire ourselves to become part of a network in a positive manner. All these 3 positive examples of feedback come from women's endocrinology. The first is the LH surge. So around ovulation, there is a surge in LH. That surge in LH kickstarts a positive feedback mechanism, which allows for ovulation. After that, pregnancy will occur, hopefully, if the couple is planning for that. And then at the time of delivery, again, you have a positive feedback mechanism, and that is from oxytocin. So uterine contractions, oxytocin, high oxytocin, more uterine contractions. And lo and behold, you have a beautiful baby in your hands. So see the strength of positive feedback, positive networking. And after that, now we need sustenance. So prolactin comes into the picture. Breast milk, prolactin, breast milk. And again, a positive feedback is kickstarted, which allows the baby to grow up into a healthy infant. So we do have negative feedback in endocrinology. We have negative feedback in life as well, but there is positive feedback. That's what we should think about when we are talking about networking. And then we also have lateral feedback. Lateral feedback, let's take examples from endocrinology. And maybe TSH and HCG, human chorionic gonadotropin, both having a similar kind of a crosstalk, similar kind of an effect in the body during pregnancy. That's lateral feedback for you. There are also lateral communications in neurology in the brain. So now we see feedback is quite complex. You have negative, you have positive, and you have lateral examples. Similarly, networking too will be complex. And when you want to network, you may want to network with your peers or professionals, with professionals from other subjects, other disciplines. You may want to network with your patients specifically or with the public at large. It might be your desire to network just with pharma or with policymakers and politicians. So it is a complex field. And before we wade into it, we must know why we want to network. Even before we want to know why we wish to network, we should know the history of networking. Now look at mankind, how we have evolved. Maybe thousands of years ago, there would be one single person and he would have a network of 3 or 4 people. So one tiny network here. In the neighboring village, there was another network. So you had 2 networks. They were not able to communicate with each other. Then one fine day, a very brave traveler decided to make his way to the next village. And so they became connected by that single traveler. Today, communication is so easy, face-to-face as well as online. So now you have so many people all across the world, but all are able to communicate with each other. So you have a jigsaw of communication. You might wish to get confused by it, but why so? Why don't we take advantage of this strength? And why don't we begin networking? But if you were to wade into this maelstrom or this confusion of networking, you may get lost. So the first request to all of us would be, we should know why we want to network.
At different times of your professional life, you may have different reasons for networking. Today, I may wish to network with other people in diabetes care because I want to learn more about technology, let us say. Then I may realize I've learned about technology. Technology is talking about diabetic retinopathy and artificial intelligence, but I want to learn more. So let me reach out to an ophthalmologist, maybe to an expert from artificial intelligence or information technology. That is my need today, so I will network with these people. It is also possible that I feel I know all there is to know about artificial intelligence and about diabetic retinopathy screening. So let me spread this message with to my patients. And why only to my patients? Why not to the public at large? So then I will begin networking in that manner. I then may feel I have a beautiful product in my hand. I want to tell everybody about diabetic retinopathy and artificial intelligence. But I need help. I need to reach out to more people. So let me seek assistance from people in pharma, people in the industry. That's fine. So I will do that. And then if I feel that I'm on such a strong wicket, and by the way, cheers to our under-19 team for having won the World Cup, under-19 World Cup. If I'm on a strong wicket, then I may want to reach out to politicians and policymakers to make diabetic retinopathy screening a part and parcel of all our national healthcare programs. So depending upon my need, depending upon my wish, my preference, I will network with a particular group in society. And I can also choose to network with all of them at the same time. But I should network because even Vidur in the Mahabharata said that plants that grow in parks and princes who live in palaces are doomed, with a capital D, doomed to stunted growth. So if you feel that you've done all the networking there is to do, you are king of your clinic, that is fine, that is correct, and we wish you all the best. You feel that you are prince of your nursing home, that is also correct, and again we wish you all the best. You feel that you are the most popular, the most well-known doctor in your city, in your district, in your state, that is also fine. But why don't we grow one step further? If we actually have goodness in ourselves, why do we not spread the good word? And how will we spread the good word? That will be through a network. So if, as plants, we come out of our parks, and as princes, we come out of our palaces, then that is real growth for us. The Hindi equivalent doesn't sound all that nice, and that is actually, if we translate into English, that is the well in the frog in the well. So if you don't network, you end up being like the frog in the well. That is the only life that you will see. But there is so much of life beyond that well. So don't be like a Kuenka Mendak. Try to be like a prince who comes out of his palace and then conquers the entire world. Is this easy to do? I would not say so. It is actually tough, especially if you happen to be a bit shy, if you happen to be a slight introvert. But if you have this aim in your mind that you really want to network and you want to network for a cause, for a purpose, for meaning, then you will be able to do it. Why not start with our class groups, your alumni class groups? Maybe local organizations like the Rotary Club or Women's Club. Join a professional organization like Endocrine Society of India, RSSDI, Association of Physicians of India. Once you join them, find out if you have a state chapter. You can join international organizations as well. And go to social media. Go to LinkedIn, go to Twitter, go to Facebook. See if there are people who share the same interests as you, the same concerns as you, and reach out to them. The beginning is tough, but well begun is half done, and you will actually be able to manage. Even Rome was not built in a day. And one by one step at a time, you will actually be able to create a great network for yourself. I am reminded of this Hindi saying, "Kahin ki eent, kahin ka roda," a brick from somewhere and maybe a pebble from another place. "Kahin ki eent, kahin ka roda, Bhanumati ne
Kunda Joda. And Bhanumati was able to get the entire community, the entire society together as one. Just a historical nugget. I am from Karnal, which is in Haryana. Right next door to us is Kurukshetra, where the Mahabharata took place. Vidur, whom we quoted just a few slides ago, was half brother of Dhritarashtra. And Bhanumati was from Odisha. She was daughter-in-law of Dhritarashtra. And she was good friends with Karan, her brother-in-law. Karnal, where I live, happens to be named after Karan. So that's a separate issue. But let's continue with this journey of networking now. We've seen that we can begin. We do have access to all these things that we have mentioned. But once you begin, you shouldn't stop. And follow what Bhanumati did. Expand in width and expand in depth. Let us say you are good friends with people in your city, in your district. Why don't you spread? Reach out to people from neighboring districts, then from neighboring states, then across the country, and then beyond the country. Expand your width in terms of cognitive spectrum as well. Today, you are an expert in insulin. Tomorrow, why don't you focus on SGLT2 inhibitors and GLP-1R? Today, you've been delivering lots of talks on sulfonylureas. Why don't you try out a talk on thyroid or on metformin? So keep on expanding your width and also increase the depth. So increase the quality and the frequency of the relationship and the interaction that you have with your fellow peers. Let us spend a minute on this slide. And let me talk about my history. When I completed my fellowship in endocrinology, I came back home. Home is Karnal, which is a small district of a small state. There was no network at all. How did I begin? I wanted to make a difference. I wanted to deliver lectures. So I began by delivering lectures in my district, in the neighboring districts. Then a few months later, I graduated to Punjab and Haryana lectures, to lectures in the Union Territory of Chandigarh. A couple of years later, I was able then to go and speak in the Union Territory of New Delhi. And then my spread kept on increasing. I did it one step at a time. You cannot say that I don't have a network at all, and tomorrow I want to be accepted as maybe a global leader in diabetes care. It will happen, but tomorrow is not going to come tomorrow. It will come after a few years. But during those years, you just keep on expanding your spread, your geographical spread, geo spread, and also your cognitive spectrum. So keep on learning new things. So that's the way to expand networking. Now, in this journey of networking, how do we begin? How do we strengthen ourselves? How do we continue? A few best practices from my side. Let us say you are attending Chalaram Diabetes Institute conference today. You want to be part of a network. You want to network, and you want to be an alpha networker. So first of all, acknowledge the speaker. Send him a message, send a question, write a query to her. I acknowledge that you are delivering a wonderful talk on modern insulins. I am from this city, in this state. We have a lot of patients. I appreciate the quality of your talk. So acknowledge and appreciate. Then assert yourself. Whatever you said, I have been following that in my practice, and I would like to add the following things which may be of value to you. So you've spoken about how to motivate a patient to take insulin. These are my best practices. Once you assert in a positive and in a polite way, you will automatically attract attention. And you will find the speaker will say, yes, Dr. Kumar, I appreciate what you have said. I acknowledge what you have said. I thank you for your kind words. Do this once, do this twice, do this thrice. And sooner or later, you will find that you will meet that person, either in person or maybe you will be colleagues in some e-lecture. And then you will advance together.
Try this from right now. And then you will see that you will become a great advocate for networking. This is what I have done in my career. I have used my patients as endocrine evangelists. The kind of patients who talk a lot in the OPD, who ask a lot of questions. Sometimes I get irritated, but then I suppress that irritation. And I say, thank you, madam, for asking all these questions. It shows how concerned you are about health. This is what we have to share with you. Insulin is a good drug. HbA1c7 must be achieved. You must get a thyroid test done every year. Why don't you spread the good word? So whenever you are speaking with your friends, do tell them about this. They will be grateful to you for having helped them in their health. And automatically they become evangelists or ambassadors for my practice. Another best practice, I was lucky enough in the initial part of my career to tie up with my peer group, Dr. Unni Krishnan from Pune, Professor Rakesh Sahay from Hyderabad, Professor Ganpati Bantwal from Bangalore, Dr. Manas Barua from Guwahati, and Dr. Matthew John from Trivandrum. All of India in one tiny group that we call PEER, Partners for Excellence in Endocrine Research. And all of us have grown together in our professional and personal journey. This led to the creation of SAFES, South Asian Federation of Endocrine Societies. SAFES is a very strong and vibrant society today. But how did it come into being 10 years ago? Kahin ki eent, kahin ka roda, Bhanumati ne kunba joda, and that is how we all got together. Now we are 8 countries strong. SPEED is a Delhi-based organization led currently by Dr. Sameer Agarwal from Rohtak, and the earlier president was Dr. Saptarshi Bhattacharya from New Delhi. They have been able to create a very meaningful impact in endocrine education, not only in North, but across India. Another best practice I would like to share is offering value to pharma. Instead of always demanding and asking for things, why don't you offer value? And you will find that you will be welcomed into every network. Whatever value you can give in terms of prescription, that's fine, but that is just going to be a paracrine effect. If you really want to add value, go beyond prescription. Prescription is paracrine. Education is endocrine. Share your education with everyone. You might want to share it with your patients, with the public, with medical reps, with seniors in pharma. Just do it and see what happens. See how the network grows. So when a medical rep comes to you and maybe details something which he doesn't understand, see, he is not an MD medicine. Instead of scolding him, why don't you spare time to teach him? Something like in Hindi, I will say, Kake, English ka spelling galat hai, isko theek kara lo. Right? Or something like, insulin aise nahi hota, aise hota hai, let us teach you. And then when the manager comes to meet you, you say, yes, I enjoy this. Why don't you get me a lecture in my city? You've already done 4 lectures. Why don't you get me a lecture in the state capital? You've done that. Then you say, young man, thanks for all your support. I would really like to go and speak in the neighboring state. And this is how your network will grow. But do remember this slide forever and ever. If you focus only on your prescription, you will end up becoming like a paracrine gland. But if you focus on prescription and education, then you will have an endocrine effect. And you will have the value of the hypothalamus or the pituitary or the adrenal or the beta cell. Life cannot sustain without these glands. Okay. We have spoken so much about endocrine physiology. Let's also talk about ego and teamwork. As part of a network, you are part of a team. So let go of individual ego, please. Otherwise, it will just end up being a fight between insulin and glucagon. Learn how to de-stress the islet of Langerhans in diabetes care and learn how to de-stress yourself and your ego.
Hello. Okay. So sorry to interrupt. Actually, we were overshooting the time. So we can go ahead with our next live session. Dr. Khaire, would you like to introduce the speaker?
Yes. The third important topic today that we want to experience is the application of technology in daily diabetology. And to speak on this, we have Dr. Ameya Joshi, who's an endocrinologist, adult as well as pediatric, and a diabetologist working in the western and north of Mumbai. He's done his post-graduation from the Grant Medical College, worked as an assistant professor at the Tokyo National Medical College. He's taken special training in the advanced diabetes management at Belgium. Apart from that, he's also has a special interest in thyroid disorders, metabolic bone disease, endocrine tumors, and reproductive endocrinology. He has been instrumental in establishing successfully running the endocrinology and diabetology clinic at the Bhakti Vedanta Hospital at Meera Road. So I welcome Dr. Ameya Joshi to speak on an interesting topic of the use of technology in the daily diabetes management.
Yeah, thank you, Dr. Khaire. Am I audible to you?
Yes, Dr. Joshi. Welcome, Ameya.
Thank you, sir. Thank you for inviting me for this wonderful program, which continues to set new benchmarks every year. And I hope next time you will feel free to invite me to Pune.
Yes.
Next 15 to 20 minutes, I will be taking you through applying technology in daily diabetology. Let me tell you that nobody has escaped technology. And technology is a vast thing. You can have a separate workshop on that. But I must tell you that I'll try to stick to what I have done, I have used, and what may be useful to some. Rest, there is a lot of technology like YouTube and you can learn. But I must tell you that in today's world, if you don't use technology, you may seem not to exist. Like in today's program, if I go home and don't show my wife the photograph on Zoom that I'm delivering a lecture, she might also start doubting me. And I must tell you that many people, when I started practice, and actually they used to come to me referred by some doctor, used to say, sir, aapka online nahi hai kahin. You are not on Google, you know. We don't think that you are practicing. And that led me to have a Google listing, my first introduction to technology in management or day-to-day practice. Also, the hospital where I run the department has a website, and that's the first introduction to technology for everyone. Make your listing. There are something called as SEOs who optimize your listing and help you be found easily, which helps you get patients, but also helps your patients who are planning to see you locate where you are, maybe at times how you are, and essentially what you do in your day-to-day practice is attend patients. That's what I thought, you know, that as a doctor, what I am supposed to do? I'm supposed to see patients. Whatever revenue comes to me, I'll take home. But then I realized that it's not as simple. I have to see patients by appointment, because if I ask someone to come and wait for 2 hours, that's not fair. I have to address their concerns while giving their care. I have to maintain their records. I must tell you, if you are just kicking out patient and writing a prescription, that's not right, because you may be called sometime. And obviously, if you want to be good, you have to keep on improvising. What's easy is actually an access to softwares. There are many free softwares also. And if you don't want to buy, just give your secretary an Excel sheet, because tomorrow, even your municipal corporation, if it lands up in your clinic, or if an income tax person lands in your clinic, they will want to know how many patients you are seeing, what you have charged them. It's a rule to maintain a list. However, if you want to go a step ahead, and many times patients will say that your receptionist is not giving me appointments. There are many who just want to crib also that, okay, she's rude, she's whatever. You tell them to call an IVRS. An IVRS is a machine. They can't argue. If they argue, the machine doesn't get angry. She just tells them, this is an appointment available. If you want, you take. If you don't want, just switch off the call and maybe whatever repercussions you have to bear. But to ease out, a lot of patients now like to take what is called as automated appointments. So this is an automation portal of the hospital where I work. And you just click on the time slot, choose the slot, make the payment, and I myself encourage my patients to book their appointment a month in advance. So at times it is better to adapt to life, and patients do appreciate, for emergency, there is emergency department, doctor's appointments are full for a month. So okay, we'll book it in advance, but at least we know what to do. And it's at times good to be honest. And yeah, if you are starting a practice new, many patients don't like physical interaction on a call with the receptionist, but are very, very happy to book it online, and they appreciate that. As I spoke about IVRS, I must take you through an interesting phenomenon called as chatbot. It's a chatterboard is a software application which actually gives you a simulation as if you are talking to a human being online. Bhaktivedanta Hospital has a chatbot. Even Chilaram Diabetes Institute has a chatbot. And so they can interact, and usually the artificial intelligence starts getting better and better. Currently, it is costly and may not be affordable for an individual clinic, but it's worthwhile if you are going in a hospital. And then there are virtual receptionists, which we had an access during the COVID time. There used to be, my receptionist used to work from home, but she used to be available on screen. Also, it's always good to sit in front of a computer and consult, because patient can come with a rare condition and you really don't know. Patients can come with a genetic analysis report and you really don't know. I mean, I'm quite open to accept the fact that at times my knowledge has limitations, and then patients can come with maybe medications and you don't know how they interact with you or your medications, and maybe you would like to check, and just feel free to use these softwares called as Hippocrates or WebMD. Many times patients are using alternative medications and you don't know the contents. Sometimes, something like Jeshtamad, which contains mineralocorticoids, can contribute to rise in blood pressure, and patients can have queries like a gentleman who saw me a couple of days ago says that he is having loss of libido due to post-PHENAS syndrome. Oh my God, I was taken aback. I never had read about this. And then when I just looked at the computer, in a second, I realized what he meant. I sorted out. I did not look like an idiot to him, and we had a meaningful conversation. The most important thing is risk stratification. Let it be an osteoporosis, let it be diabetes. It's always good to stratify, because a patient who came to me, 35 years of age, LDL cholesterol of 210, wasn't willing to take a statin, had differences of opinion amongst 3-4 physicians. I showed him an ASCVD lifetime risk score and the guidelines. In a minute, the conversation ended there. He was willing to take a statin, and we managed to have a meaningful outcome of a consultation. The EHR is a hospital record, many consultations having an access. EMR is an individual clinic record, even only you can have an access. But remember that EMR clarifies the prescription. Let us accept the fact that my handwriting is not good. Many of you may not be having a good handwriting. Secondly, first consultation is more detailed, it takes more time. Follow-ups are like a song. If you have an EMR, it gives you storage. A patient comes to me after 2 years, I tell him, okay, this and this is so. Patient comes to me after 1 year, my charges are increased. I say, if you have not followed up for 1 year, you have to pay a first consultation. Patients used to say that 6 महीने पहले दिखाया था, भूल गया, paper गुम गया. Now I tell him, my record doesn't show, you please do this, and so on and so forth. What is important is that you have a record of at least 3 years of a patient. Now you are not tech savvy, you cannot type, you find it's cumbersome, and it's really not in what you have done in last maybe 20 or 30 years of practice. Use these wonderful softwares like Evernote or SmartPen. Evernote is a software that makes you store what you have handwritten in a searchable manner. So if you upload 1,000 prescriptions and then just Google hyperparathyroidism, all those prescriptions that contain hyperparathyroidism in a whatever handwritten manner come to your screen. A smart pen also helps. You write and then it's a special pen on a special paper, it transfers it to a computer. Can you have an EMR for free, EMR that is customizable? I must say, just try these two things before you actually buy an EMR. Make a Google form of your consultation or make a Jot form of your consultation. These are free softwares. Let your secretary fill them. These are analyzable, and every patient you get a summary. Once you are ready with the Google form, then only buy a software. It makes your job so easy. Remember that there is something called as HIPAA compliance for a doctor's office, and there are certain norms. There is no Indian HIPAA compliance, but there is something called as DISHA compliance, which is in the Healthcare Act, and we need to be mindful about the software that we use. What has found a flavor is telemedicine. Even if the COVID pandemic is tailing, our teleconsultations have continued, and daily we have at least 4 to 5 teleconsultations. Patients have tried to remain in touch even if they are outstation, even if they are abroad. You should be mindful that entertain only those requests which you can. Preferably, you should have seen the patient in a reasonable period of time, and don't do therapeutic misadventures. Don't prescribe medications which can cause or you foresee causing side effects. Don't prescribe psychotropic medications, and if the patient is willing to come, don't force a telemedicine on him. Now let us try to look at what telemedicine more can do. Diabetes management needs motivation, and you cannot talk to the patient daily. You don't have time, you are loaded with the patients, but your educators, your dietitian always can talk to the patient from time to time. Patients cherish that, at least some of them don't like, but then you can always move on. You can give them advice dedicated to prevention. I must say that we neglect pre-diabetes and mild hypertension. These can be managed by an educator. Patients will actually like that. Nutrition, you can give advice from time to time. They definitely have queries. They definitely have somebody is working from home now, goes to an office, and these changes can be done by your nutritionist. Your headache becomes lesser. Physical activity motivation, advice about stress management, advice about um, minor concerns and all can be done from time to time. Also, patients' diet can be reviewed, patients' SMBG can be reviewed, patients' continuous glucose monitoring records can be reviewed. Make sure that if you are a private practitioner and putting your brain into it, please put charges on that so that patients don't take you for a ride. But I must tell you, if you are actually streamlined, if you put a value on your services, you can actually deliver better, and you can see a meaningful glucose reduction as seen by this particular study, that no medication, only telemedicine, no medicine, only virtual contact can lower your HbA1c as much as one OHA can do. Also, there have been titration algorithms, and one of the main cornerstone is insulinization. And if you give insulin, you have to motivate the patient. If you motivate the patient for insulin, the worst outcome is the patient coming back with a poor glucose control. Common fact which happens because of lack of titration of insulin. And this titration, whether it is basal or bolus, excellent apps are available. You can do it online. Your secretary can do it online. And if you are looking for investment ideas, just try to look at digital therapeutics. It's a small field, it continues to grow, and you can actually use it in your practice, but also invest in these companies. There are a lot of applications who are now using artificial intelligence, analyzing patients' behavior, giving him a more accurate advice, also analyzing what has happened. And now the whole focus of medical research is at one end creating the data, like so many patients' behavior, so many genes, but analyzing the data so as a personalized advice can be given. Similarly, predicting what the patient can do in over a period of time, predicting whether the patient will respond to this particular medication or not by analyzing the patient's behavior, patient's phenotype, patient's other aspects can actually help you out. And these applications can help the patient have an HbA1c reduction. Wealthy, Fitterfly are common applications which my patients are using from time to time, and it gives them a good result. There are many fields beyond diabetes, obesity, all chronic diseases, and even COVID to a great extent, We saw the power of digital therapeutics, and I think all the medical fraternity did a wonderful job. What we also did in this COVID pandemic was to create our YouTube channel. You don't have time to explain everything. Diabetes education needs at least 2 to 3 hours. We made a YouTube channel, some videos, how to check sugar, how to take insulin, how to care of hypoglycemia, and more importantly, our patients themselves gave us exercise videos and we posted them. And most of the times the patient had a question, sir, what should I exercise? And it was a wonderful thing. This is the video, you look at it, scan a QR code in the clinic, and they used to really enjoy that. Moving ahead, we can have technologies which help monitor glucose and which help in the gentle device helps you in pricking at random places. Salivary glucose monitors, we are going to see them soon, and ketone monitors are there. Patients, the commonest thing that a patient miss are retina examination, and we have seen in the study from United Kingdom that this actually does better than ophthalmologist referral. Many times non-mydriatic fundus camera office hour examination, not only it gives you more revenue but also eases out. Just recommend fundus examination to 100 patients, I am sure 50 patients are not going to come and get it done. It's always better to have point of care analyzers. I must say can be debatable, sometimes their reports are unreliable also, but a good number of times they are handy. And at least for tests like HbA1c, lipid profile, CRP, microalbumin, they come very, very handy. These are a good number of smart instruments, so can say real-time monitoring, home monitoring, all of them can help. But let us try to look at in last 2 to 3 minutes about two common real-time instruments. One of them is ambulatory BP monitor, which gives you about a circadian rhythm of BP. If the patient says my BP is 150/90 here, but most of the times it is normal, give him an ambulatory BP monitoring, calculate his BP load, estimate his BP load, and be prescriptive and describe him what the ambulatory BP monitoring I said. It can pick up even certain changes like lack of nocturnal dip and few more. Canadian Hypertension Association in fact says any BP below 180 should be subjected to ambulatory BP monitoring and then only decided. Second is a continuous glucose monitoring. Our world has moved from fasting and post meal and HbA1c to time in range and glucose variability. Either you have a glucometer data or you have a CGMS data. 10 years ago, CGMS was a rarity. Now it's a common thing. There are recommendations on how much your time in range should be. And if the CGM comes down in price further, it's not difficult to imagine that most of our patients will actually have these machines fit and they will send us the log or they will send us the charts, and maybe HbA1c may become absolute. Wonderful thing that has happened is closed loop pump. Medtronic just launched one in India, and we might see more. And what is more wonderful is a smart insulin. And this is how the diabetic digital environment has changed. We have a digitosome, we cannot escape from it. We have to incorporate it. How much we incorporate depends on the surrounding that we are working in as well as our desire. It goes without saying that patients will say that I don't want to handle cash, I don't want to do this, I have not brought enough cash in the clinic. You tell them just scan this QR code, your bank account should be linked. If you don't have an app, download the app. I will always be comfortable if you make a payment in the clinic. You can save a lot of time, energy. You don't really need to give the 2% that you have to pay for the credit card vending machine, and the amount directly goes to your account. And nowadays you don't really need that Paytm person should pay to Paytm or Google Pay need to Google Pay. I think I will always suggest looking at the Russian lesson. Always be Indian. Always have the Indian payment interface, that is the beam marketing. I would always advocate that. Also, let us remember in the end that intelligence, if artificial, will always have limitations. Computer does not have compassion. Medical fraternity will always remain, continue to evolve, maybe evolve ahead of computer, and will feed the computer to become better. It will not substitute the clinical acumen that people like Unni sir or Dr. Kalra sir have, or the ability to counsel the person right. And that's why many fields may experience artificial intelligence taking over, but probably medical fraternity will continue to have the empathy which the computer can never give. The possibilities are unlimited. We have a lot of things like precision medicine, handmade treatment. Maybe 10 years down the line, the guidelines will say that this patient gets this patient gets this patient gets this. You will have a screen in front of you. You will enter the patient's characteristic. The patient prescription will be automated, and you just have to do some little bit manipulation based on your experience. Remember, your experience doesn't come from artificial thought process. To summarize, no one has escaped technology. The extent of involvement can be individual. Lack of facilities have been to a great extent made up by technology. As I said, I don't have too many people in the clinic, but there is a virtual educator. In COVID, I had a virtual receptionist. At times, my dietitian, if she goes on a leave, I tell her to work virtually. And future of diabetes treatment as well as chronic disease treatment looks very, very exciting. In the conclude, I would like to take you through what Elon Musk once said, that you can literally learn any skill from YouTube. You can become a person of value in a matter of months. Just a few years ago, this wasn't possible. And I am sure that Chelaram Diabetes Institute, this virtual summit will be available on YouTube. And whatever lectures I have missed, I should be able to learn later on or go through later on so that I can make a most of my learning experience. I thank one and all for your patient listening. Thank you.
So thank you, Dr. Karthik, Dr. Sanjay Kalra, as well as Dr. Amya Joshi. I think the sessions are fantastic. And I'm sure Dr. Pushkar Kher, who is our, who's a local tech doctor in Pune, because he's also a physician, internal medicine specialist, and also got a lot of digital interest and is technology inclined. Dr. Pushkar Kher, what did you feel about the meeting? And please take over the discussion. We have about 10 minutes time to take over the discussion.
Right, sir. Thank you so much, Unni sir, for that introduction. And let me tell you, I mean, having a thought of keeping such a session in this was itself a big and a wonderful decision. And I was always looking forward to be a part of this. Chairing it was a cherry on the top. What I got from this session was a very 360 view of technology, networking, in the whole aspect of clinical management, diabetes management, and endocrinology as such. What Kalra sir mentioned was, of course, why of the networking. And that reminds me of a very interesting study that is still going on at the Harvard, which is called as the longest study on happiness. And they just are studying a bunch of teenagers, and they've been studying their lives and trying to find out one thing that actually keeps somebody healthy, happy, and probably away from diseases. And the one thing that they actually have found is that a person who is good in networking actually survives better with lesser diseases, apart from many other factors which were not that significant. The beautiful thing that I found about Dr. Balchandra's lecture was humanizing a digital presence. I think with the growing practice, what a physician wants is a growing rapport with his patients, and having the digital to leverage that possibility of being able to build rapport with the patient even before they have come to see you. I think that's a wonderful possibility. And of course, Dr. Amya Joshi, I think, touched upon beautifully many things, right from being a digitally present doctor for as an available doctor for consultations to the technology which enables education of patients. That was wonderful. Being in this digital space, going further, what I can see Mark Zuckerberg is doing is spreading the message of metaverse. And metaverse is something I think is going to be the near future where communication is going to happen. Use of virtual reality to educate patients in an immersive way is going to be the next fantastic thing that's going to happen. And I think all of us are going to live to see the fantastic effects of it. Thank you very much, Unni sir, for this.
My question to Dr. Sanjay Kalra is that, staying in Karnal, you are today the most well-known endocrinologist from India across the world, right from you've built connections in Africa, Middle East, Australia, US, South America. I mean, people in big cities are not able to make that kind of connection. How did you do so in Karnal? I know Karnal is a big city, but even then, it's not like Delhi or Bombay or Calcutta. How did you manage to make such a huge network? And that's always amazed me. And though Dr. Sanjay Kalra is of course, Dr. Sanjay Kalra is one of my closest friends. So I have a little bias towards supporting him. But even then, he's the most amazing networker I've seen. Could you share some secrets for everybody?
Well, Kanal is not all that big a city. Our population is about 3.5 lakhs now. So 3.5 lakhs, of course, is reasonable by Haryana standards, but not by India standards. I think the trick is in realizing how life is changing. Earlier, maybe you would look at a monarchy or an oligarchy. The system of connection of networking was there is one big dot, one big center in the middle, and then that dot connects to different people. Let's take an example of the railway system. In England, even today, if you want to travel from, let us say, the northwest of England to the northeast of England, first you have to come to London, then you go back up again to the other city. So all the connections are routed through London. This is what happened in India earlier, before partition. And there is a term in Punjabi language, which is Via Bhatinda. How did Via Bhatinda come in? Because if you wanted to travel by train from Karachi to Bombay at that time, first you have to go all the way north up till Punjab to Bhatinda. That is the nearest junction. And then you come down south to Mumbai. So earlier, all the connections, all the networking was via Bhatinda or via London. If we realize that that system does not operate anymore, now it is multiple dots all interconnected with each other. Just like we have our neurons, Brownian motion. So if you are able to connect with multiple dots at multiple places, make one friend, like my best friend is Dr. Unni Krishnan. Through him, I get introduced to another friend, and through him to maybe another one. So automatically the dots connect. The keyword perhaps would be humility, understanding that har ek friend zaruri hota hai, and also understanding that the endocrinologist or the physician who is working in Bangladesh or Nepal has an equal right to your attention, is equally deserving of your attention as compared to the ones in New Delhi or Mumbai or London or New York or the other corridors of power. I think if we go with that humility and with that open-mindedness, automatically the ecosystem becomes a wonderful place to live in. A wonderful place to live in.
Thank you. And quick thoughts from maybe Dr. Amiya Joshi. Wonderfully said, Dr. Kalra. Quick thoughts from Dr. Amiya Joshi. Technology in clinical practice. Where is it headed?
Yeah, I think it is headed in a direction of analytics. I mean, your sir's question was very pinpoint. I will not say where it is now, but maybe where it is headed to. And what I feel is that it is headed to a more orientation towards analytics, and which will guide us. So most of the times you will be recording your past descriptions of the patient. The computer maybe will tell you that you will have to look at this and you will just have to fine tune your advice. If you are doing something odd, the computer may just remind you that this is not as per the guidelines and maybe you need to have a relook at it. And at the same time, you will have to be authoritative for what you are doing. I think we all know a simple thing, that whole genome sequencing just Diabetes Institute, I had an opportunity to interact with few scientists there, and they knew that in next few years, the clinical exome sequencing, which is now 18 to 20,000, will come down to 5,000 odd rupees. And every patient will come with his exome sequence and say that, okay, doctor, in addition to my sugar report, these are my exomes, and let me know what is the best medicine for me, what are my risks. I think analytics and analysis is going to be the future of medicine in next few years, or maybe a decade or so, is what I feel, or at least the feel that I got when I came last time and saw or met few colleagues at ICER.
Thank you. And we are running completely out of time, but marvelous lectures by Dr. Karthik, Dr. Kalra, Dr. Joshi, and of course, our own Dr. Khair, the local tech guru here, and a doctor. And maybe we'll listen to more from another master of innovation, Dr. V. Mohan sir is already here. And Dr. Kulkarni. Is Dr. R.B. Kulkarni here? Otherwise, I'd like to take this opportunity to introduce Dr. Mohan. Is Dr. Kulkarni here?
Due to some personal reason, he's not able to.
That's I've always it's always an honor to introduce Dr. Mohan because I consider myself an Ekalavya to many Dronas, Dr. Kuchipillai in Delhi, Dr. Amrish Mittal, Dr. Mohan, even my friend Dr. Kalra. So many people. I'm an Ekalavya to so many Dronacharyas, and Dr. Mohan is also one of them. Dr. V. Mohan is unquestionably the leading diabetologist of India, Chairman and Chief of Diabetology at Dr. Mohan's Diabetes Specialty Center, President and Director of the Madras Diabetes Research Foundation, awarded the Padma Shri by Government of India, and also heads India's leading diabetes chain. Has just got the award from the Times of India for that. Congratulations, sir. And he's going to talk about how to make excellence a habit. And he's written a wonderful book about that as well. Like me, he's a big devotee of Satya Sai Baba. And over to you, sir, for your presentation.
Thank you, Unni. I'll just get my slides. It's visible, no? Visible and can hear me.
Yes, sir.
Okay, thank you. Thank you, Unni. And I've been enjoying the talks before this, and congratulations on yet another edition of CDI. It's going from strength to strength, and I'm sure with all the pioneering efforts that you take, you're really putting India and diabetology on the world map. So I'm very proud of the work that you do, and all the rural work and all the social service that you do, apart from all the research. And the program this year has been really, really good. So congratulations. I'd like to congratulate all the other organizing committee people who help you in this. Actually, I think last year also I spoke on the same topic of making excellence a habit. So probably I must break it next year, talk on something else. But Unni was very particular that I talk on this. So for those of you who have heard me before, probably this is the time to switch off and go and get a cup of coffee and relax, and then come back after my talk. So my apologies. But the only thing which kind of prompted me that even if somebody has heard it, it's probably you can still hear again, is I used to remember Professor Sam G.P. Moses, because I was associated him for over 20-30 years as a student, postgraduate, and then as a colleague. And he used to crack some of the same jokes all over in every meeting. I'm a verbal diarrhea, I'm this, I'm that, and so on. And it was so enjoyable because the way he used to say it was so humorous that we know what's coming, but in the audience, 90% would not have heard him. And they'll be, roaring with laughter. And for us, after hearing him for the 1000th time, we would still enjoy it because the way he puts it was so funny and so nice. So in that, brave note, I think even if those of you have heard me before, and you might find this totally monotonous, I'll go ahead with this talk. So I have no conflict of interest to declare. Most of the studies are funded either in India or from abroad. I'd like to, this is more of a philosophical kind of a talk. There's nothing much of science in it, although I'll bring in science. I think difference is that last time when I spoke on making excellence a habit, I spoke on all aspects of it. I think healthcare, education, charity, and then also brought in research. This time I thought I'll focus just on research. And the reason I'm doing that is because just yesterday, we had the meeting of the Indian Society of Clinical Research. And there we are trying to say, how do we get people enthused to do research and to have their interest going for some time? And the limited point that I made was that you have to start early. You have to get youngsters very early into their talk. And if I got into diabetes, is because of my father. Circumstances which are explained in the book led him to leave Stanley, an institution which he started the diabetic clinic, the first diabetic clinic in India. And as I had to help him being his eldest son, he kind of brought me in at the age of 18 to start not only medicine, but also to start diabetes. And therefore, I pay my respects to him. But where did we start is worth mentioning, because a lot of people think that everything was on a plate, and there are, I've heard people even criticize me saying that There's nothing in what he does. He had everything on a plate. The whole empire was kind of handed over to him. And then from there, he had to just, be there. That's it. That's all. Well, that's not really true, because when we started with my father, he had didn't have a research center privately. He didn't even have a proper clinic privately, because he had been doing all his teaching and the diabetes work at Stanley. It's only in 1971 that my father really started practicing diabetes full-time in practice. And that's the year I joined him. And together, actually, we built this. And, it was like a car shed. So from the beginning, I told him that we need a research center. That's one of the conditions I laid to him before I took up medicine. I said, I just don't want to do medicine. I don't want surgery. And he said, what do you want? I said, I want research. And that's what I would like. So he said, okay, find one room and you take it. So there was a car shed, and that car shed, with cobwebs and bats and rats and all kinds of moving things and insects and that. This was the place which we took, and we started refurbishing it and making it into a small lab. So that's me when I joined him when I was 18. And this is much later when my father visited me when I was in Germany, when I was doing my Alexander von Humboldt fellowship in Germany. So it was actually he who played a large role. But there's one other person I must mention, and that's Professor Lalita Kameshwaran, professor of pharmacology. She is also the mother of my closest friend, Mohan Kameshwaran. We are called the Mohan twins. And so she was like a mother to me, and she sensed my interest in research very early. And again, there was another dilapidated, animal house in Madras Medical College, not used for years. And she said, you take that and you renovate that also, and bring in something, clean it up, and then you can start doing your dog experiments. So I actually started doing dog experiments when I was in, and the rest of the people were studying pharmacology. I was doing dog experiments. And she later became the first vice chancellor. And here's one of the early papers with her, where we produced, I was doing clinical work with my father, and then the animal work in the lab. So we started we produced diabetes in dogs. We looked at normal dogs, diabetic dogs. We did subtotal pancreatectomy in dogs, and then started looking at the effect of, we had only glibenclamide and penformin. Metformin was just coming in, it hadn't come in and not being used. Penformin is much cheaper. And so a combination of that and seeing how it helps as compared to giving double the dose of a single drug and so on. And all this was when I was in third year when I was doing my pharmacology. Then, of course, we started doing, and in my father's center, there's no computer. And of course, remember, there's no Google, no internet, no PubMed, nothing those days. So we needed any journal or article, I had to go to Delhi to the National Medical Library to get it. There's no library in my Madras Medical College library was kind of defunct. Most of the journals were not there. But up to 91, I continued with my father. First 10 years as a student, next 10 years as a full-time consultant in diabetes. And by that time, about 250 papers had already come out. And this was with virtually no funding, because until then, ICMR, DBT, DST, nobody would fund a private institution. They said, it's not your job to do research. That's the job of medical college. Why are you even attempting research? So it's very difficult to convince them. But despite that, using all the clinical material that we had, mostly handwritten notes and no computer even to go through, that's how we published our first. Then somewhere around 1991, my wife and I, we decided to leave. And then, because when I was 18, you start. After 20 years, you feel old at 38. When people are just starting, I felt already retiring, I think 20 years already gone. Now what do you do? So you have to look for new challenges. So my father said, okay, I'll add to that challenge. I'll send you without a single rupee. Take your stethoscope and leave. Now let's see what you can do. I think that's the best advice and the best thing that he did for me, because otherwise I don't think I would have achieved what I've achieved subsequently. If he had sent me with a lot of money and a lot of things, I don't think I'd have worked hard at all. So one of the things in which I disagreed with my father was the setting up of the research foundation. So while we had a research foundation, that was my starting point. I told him I'd take medicine, I have to do research. Later on, I told him I need a research center, I need a building. He said, now we are talking too much. You're going too much. This is nobody can do privately when they're not even giving funding for a project. How do you can expect a building and staff? And this is all too much, he said. I said, okay, then let me go. Let me try it on my own. So in 1996, we set up the Madras Diabetes Research Foundation, again in a single room, because by that time I'd moved places and I had a small clinic. In that one room, I set apart for research, 100% non-profit organization. This is the room. You can see it's actual photograph of the room. We had just, actually it was a toilet, and we converted the toilet into a room. But I've hired one PhD because I knew that without a PhD, I will not go far. Just doing clinical work all the time will limit the standard of the research. So I hired my first PhD with one staff, one room. And these equipments I bought myself. I didn't have any money or anything. And then with that, we started doing. But from there, the growth was quite large and quite fast. Today, we are in 4 locations. The research center alone, I'm not talking about the centers, which are in 51 locations, 32 cities and 8 states, and 51 branches are there. I'm not talking about those at all. I'm talking about this research foundation, which is 100% non-profit. We don't have a single rupee income. Anything has to come from either donations or from grants. And that we start with, we built a separate block next to a hospital block. You can just see the end of that. That's a hospital block. And next to that was a piece of land. We bought that and built a 3-4 storied building only for research. And then we found that was not sufficient. So we went on to get the next plot and the next plot, and we went on getting place for the research foundation. Finally, the government gave us 6.5 acres of land in Siruseri, in the outskirts of Chennai, where we built this 34,000 square feet facility, which is Asia's largest research foundation. Now, this entire thing is non-profit. Not a single patient comes in, not a single rupee is earned through this. But the collaboration started coming. So various universities started coming, national universities, international universities. I'll show you some of the list. Then ICMR finally woke up and said, yeah, now we have to support you. Then ICMR supported us, DST supported us, DBT supported us, Wellcome Trust supported us, NIH supported us, and the list kept growing. By the time they said, why aren't you producing PhDs? I said, definitely want to produce PhDs. So then Madras University gave us recognition for PhD. MGR Medical University gave us. Then right now we have Deakin University and University of Warwick. Now, what does that mean? They don't go from here to Warwick or to Deakin to get the degree. They work at MDRF in Chennai, and then they can get the PhD from the University of Warwick in Melbourne, University of the Deakin University in Melbourne and Warwick in UK. They don't even have to go to Australia at all. They can still get it. The first and the only time to an institution that they have done it. They found the work to be good. Now, how did we start? My initial love and passion was fibrocalcific pancreatic diabetes, and that time called tropical pancreatic diabetes. So we started doing experimental work, clinical work, long-term follow-up work, survival analysis, all kinds of things. We started immunohistochemistry studies, pathology studies, surgery, all kinds of things. For 18 years, actually, I worked on this. But after about 100 papers and about 40, 50 chapters in textbook, I said, nobody's interested in this. In fact, I'll go and talk in a national conference and they'll say only he finds these diseases. Nobody else has it. They didn't even believe me that there is something called FCPD. So then that time I said, okay, enough. I'll die, doing only research on FCPD. And at the end of it, people will not even know what the disease is. So better I switch. So somewhere around 1996, I decided to switch and said, now let me get into mainstream type 2 diabetes and epidemiology, which is what people want. So these are clinical studies. Then the epidemiological studies started. We started with a very small study called CUPS. I just took one low income group and a middle income group and started comparing those two. And for me, that was big because leaving the clinic and going into the community to do research, I think the first time, at least in the South and in Chennai, no clinician had attempted that. But that taught me the power of collaboration. And that taught me that without empowering the community and getting their help, you can never make it. For example, these are two. One is a middle income group and the other is a small slum in T Nagar. They're only 5 miles apart, but this gave us a ton of information. Almost 21 papers came out of that. Look at the sample size, it's only 1,300. And then we realized, about 3 years we worked on that. Then we realized that we're getting into epidemiology, we can't do this. We need to do, people said, it's not a representative study of Chennai. You have to do the whole of Chennai. Why are you selecting 2 places? It's convenient sampling. All kinds of criticism came in that. Then we said, okay, then we have to do a much bigger study. And that's how, and this is the first paper which came comparing the two, the low and the middle income group. So we said, okay, now we have to do the whole of Chennai now. And I was very happy that now we've studied the whole Chennai, and Dr. Sanjay Kalra was saying 350,000 people. Chennai at that time was about 4.5 million people. So we said, okay, 4.5 million if you study, that's the size of Singapore. That's 3 times the size of Mauritius. That's the size of Sweden and Denmark and all. So we said, okay, this is big enough for us. Then the Tamil Nadu government and several NGOs helped us. That is how we started what's called as the CURE study, the Chennai Urban Rural Epidemiology Study. This is a map of Chennai, and you can see that all the colored areas are represented, totally representative sample. We had 26,000 people out of this 4.3 million inner Chennai limits. And from there started phase 1, phase 2, phase 3, phase 4, different questions being asked, and for that different answers through various studies. 160 publications have come from there, still coming. After we started in 2000, now it's about 22 years, the study is still going on. We're still following up the same people and the whole of Chennai. This is a totally representative sample. So anything you want in Chennai, I can give you. Male, female, age, this, that, blood pressure at 80-year-olds, I can give you. The entire information will give you. So I was very, very happy when this happened, and we felt we had done something very big, a whole city we have taken and so on. That's when my daughter came to me. And so we had papers like this, we even a serial follow-up, secular trends, all kinds of things started coming. And we also got data on the complications. So the first time we got data on coronary artery disease, but because the whole population was there, 26,000 people. So it was powered enough to get all the complications of diabetes. So we had the retinopathy data, nephropathy data, neuropathy data. And by that time, we also had a rural cohort. So in the rural cohort, we had another 26,000. So based on that, we got all the rural data. And I think till today, if I'm not mistaken, this is the only data on complications of diabetes in the field setting. They have not come to the hospital at all. We have taken the equipments to the field and collected all the data. And we published series of papers in various journals about the complications of this. And this data has been quoted quite a bit. Now, then, something happened. My daughter by the time was in medical college. And just like I was always pushing my father to push the boundaries, here was, she is at the age of 18, 19, she joins me. And she looks at my research and she says, what is this you're doing, all some Chennai you're going on whole time. What is this Chennai? You're talking about India and you're talking about Chennai. Is Chennai India? She asked me one day. I said, Chennai is also India. She said, no, Chennai is not India. Then I asked, what is India? India is India. I said, what are you saying? I'm tired. That's all I can do. I've done whole city and 160 papers. That's all rubbish. This is not good, He said, what do you want to do? I want to do the whole of India. Whole of India. This is too much. She's in MBBS, The whole of India. Wow, you're, 19-year-old girl. What whole of India? What are you talking? Then I said, you finish your MBBS first. I'm not sending you whole India, not till you finish all. She finished. Then she came back. No, I finished. I want to do whole of India. I said, you can't, do your MD now. Finish your MD. Do research, but don't do India and don't go to Nagaland and Arunachal Pradesh and all. No, you're not old enough to do it, first of all. Then she finished her MD. The day she finished MD, she came back. She said, I want to do the India study. She wouldn't leave it. For 6 years, she harassed me. Then I went to Professor Ganguly, Director General of ICMR, and said, sir, I've got this crazy daughter and she's saying she wants to do whole of India. Why are you saying it's crazy? Great idea. Call her. Ask her to come and present to ICMR. ICMR will fund it. So I just took her to Delhi and they said, fund it. ICMR loved the idea and they said they'll fund it. So that's how the ICMR India diabetes study was started. And true enough, she completed the whole country. She's finished everything. Only Jammu and Kashmir is left, and Andaman, Nicobar Islands and 1 or 2 small islands are left, which she's doing in next phase. We couldn't go to Jammu and Kashmir because of the political situation. Otherwise, the whole of India is over. 27 states, national capital region of Delhi, 2 union territories. The sample size is 113,000 people, 1.13 lakh people, representative of India's 1.3 billion people. So such a study, I don't think in diabetes has ever been done. No country has studied its whole country. US has not done it. China has not done it. Australia has not. Nobody has done it. They'll select some pockets here, and that was my idea. One in the north, one in the south, one in the west. Then ICMR said, no, it's a political thing. You can't leave Bihar out. You can't leave Haryana out. You can't leave Bengal out, So you have to do the whole country. Take it or leave it. So we had to do that. Now that has also been, the publication is just starting actually, but they are in very high impact. Already 2 in Lancet. And so these publications are just rolling out. Now only we are writing up. We want to finish the whole country, but I'm sure hundreds of publications are going to come out of this. For example, this one, which she is the first author, in Lancet Diabetes, when we finished the 15 states of India. Now we finished the 30 states of India, and Lancet has accepted the next one. I think it should be out in the next 4 to 6 weeks, the full India study. That's also in Lancet. And then, came the thing, why only India? We are the whole world, and why are you only doing India? So right from one slum in Chennai, it became whole Chennai, now whole India. And now why only India? Luckily, I think next will say, why only world? Why not go to moon or Mars or something? And I must be ready for my grandson come. Probably he'll say, I want to study in Mars, all the diabetes in Mars. Before that, I think I should go. So then we talk about international collaborations. It's been growing and growing and growing. Not one of these collaborators I went to. They all came to me and they said, can we collaborate? Can we collaborate? And so I'm not naming the whole list, but it's across the world, from Australia to UK to Canada to US to many, many big universities in US, including Emory, a very big collaborator, McMaster in Canada, which I'll just show you briefly, Harvard Medical School and Harvard School of Nutrition Public Health in Boston. And let me just show you one with McMaster University. So this man is another crazy friend of mine. So he started a study called PURE, Prospective Urban. It's the same time I started PURE, same year, 2000 we started. And he started in St. John's, then added us in Chennai, then added Chandigarh, then added Jaipur, and then added Trivandrum. So we are only 5 places, about 20,000, I think, sample size. Then he started saying, why only India? Let's add China, let's add Zimbabwe, let's add Bangladesh, let's add Canada, let's add this, let's add that. So now that study, the PURE study, has now finished 15 years of follow-up. It has finished now, 250,000 participants, 25 countries, and 5 continents are included. Now, there's nothing left now. Everything is included. And what are we studying? Everything. Diabetes to hypertension to cancer to climate change to, I'm not involved in all of them, although technically I am in the steering committee, but the studies on diabetes and heart disease and all that I am involved in. For example, and these are papers that go straight into New England Journal and Lancet, because there's nothing like that. Cardiovascular disease risk and events in 17 middle and low income and high income countries. Straight away we'll send it to them. Next week, any GM will say, yeah, great paper, accept it. Which issue do you want it to come? And it will come. And this is this paper in 2017 became the most quoted paper in the whole of medicine in the year 2017. You can check that, most impactful paper in the whole year in the whole of medicine in 2017. And this one described the association of fat and carbohydrate, which kills people more, excess fat or excess carbohydrate. And we showed that in this paper. Of course, Mashid Dengan was the first author of this. And we showed that it's the carbohydrate which actually kills more than the fat. And then, of course, my own interests were there, white rice intake and incident diabetes. So my PhD student, Bhavdarani, worked on this. And we looked at 123,000 people, 21 countries, long-term follow-up for 15 years, incident diabetes. And we showed that in South Asia, where so much of rice is taken, it is one of the strong risk factors for type 1 diabetes. Earlier last year, I think January of 2021, we published this paper in New England Journal where we showed that the glycemic index and glycemic load is not associated just with diabetes, but is associated with cardiovascular disease and mortality. That means the more sugar, the more glycemic index and load you have, it's related to mortality. It's the first paper in the world I know of which is showing a link with mortality. Then again, in the same large numbers. And one more collaboration I just want to tell you is that with Dr. Venkat Narayan. Actually, when I first met him in Emory University, he just said, I'm from South. I studied in St. John's. And that's it. Then he came to visit me and he said, how do we collaborate? I said, how do you collaborate? We'll collaborate without anything. We are not going to get funding. Let us just collaborate with whatever we have. That's how I've started. Karshed always is what I started. So he said, okay, let's start. But from there, after doing some preliminary work, funding will start coming in. So we set up the Center of Excellence for CARS. CARS stands for Center for Cardiometabolic Risk Reduction in South Asia, or the CARS study. Then we brought in Dr. Nikhil Tandon. Then we brought in Srinath Reddy, we brought in D. Prabhakaran, then we extended it there to CDC. And of course, all my colleagues play a big role. So this collaboration has now become huge, just like PURE. And I'm just waiting to tell you, when it's finally announced. But I think this week we should hear that one of the largest grants of the US, called as a PO1 grant, we applied for that. and it's for the next 5 to 10 years of support to support this group. And fingers crossed, we have got the initial communication, but the money has not come in the hand and the letter has not come. This will be one of the largest grants ever given by the US to India. And that will probably keep the collaboration going for another 10 years. But I just want to spend the last few minutes of my talk talking. I cannot talk about all the departments. I just want to talk about one about which I'm very passionate. And that's our genomics and molecular biology department. And this was one of my interests. When I left my father, I told him we have to set up a genetics lab and so on. And he said, no, this is all too much. You're going beyond a clinician's thing and all that. So we hired Dr. Radha Venkatesan, who has been with me for the last 20 years now. And she and her team, this is her genomics team, they themselves have produced only in the genomics department, only in genomics of diabetes, 130 publications. And 13 PhD students have already completed. Another 4 or 5 are now doing. So she'll have about 17 PhD students only on genomics of diabetes. You can imagine what all we're working on, including genetics of type 2 diabetes, type 1 diabetes, fibrocalcific pancreatitis. But I'm going to talk only about monogenic diabetes, but this is my current interest. And some of you might have seen on 4th of March, we had a 5-hour meeting on monogenic diabetes funded by ICMR or under the auspices of ICMR, where Dr. Lou Phillipson from Chicago also participated. Now, MODY, or maturity onset diabetes of the young, has been of great interest to me right from the time MODY was described by Tattersall and Fayance. Today, as you know, MODY is of 14 types, although MODY 7, MODY 9, and MODY 11 have been dropped now. They are no longer MODYs. But the rest of the MODYs are there, and each one has its own clinical features. And the advantage is, most of these children are diagnosed to have type 1 diabetes. And if you find the MODY gene in the correct patient by looking at that, looking for the clinical features, you can completely stop insulin and change a child to tablets. And I've spoken on that in earlier CDI meetings. I'm not giving a talk on that, but just to tell you that hundreds of children now have stopped insulin and converted to sulfonylurea, the cheapest sulfonylurea tablet, which is like a miracle. So this particular department, what it's doing is really translational work or cutting edge precision medicine. So we have published on MODY 3 and MODY 1 and MODY 2 and MODY 5, and several more papers have come out on MODY. But I want to talk just a little bit about this and then finish about neonatal diabetes. And this is something which I would request every one of you, if you're listening in and if you have heard of a child diagnosed before the first birthday, please get in touch with me. I'll get the genetic testing done completely free of cost. You don't have to pay even 1 rupee. And we will tell you whether the child has one of the actionable genes, that is either a KCNJ11 or an ABCC8 mutation. And if the child has one of those mutations, you can stop insulin and change the child to sulfonylurea, as shown here in this paper. About 9 years ago, we published this. Now the numbers are much, much bigger. So you can see that these children were referred to us. They had these mutations in KCNJ11 or ABCC8. And because of that, you're able to stop the insulin. You can see when on insulin, sugar is not controlled. A1C is very high. And after stopping the insulin and changing to sulfonylurea, excellent control. You can see the blood sugars dropping to almost normal values once you have corrected that defect by giving the sulfonylurea, because the sulfonylurea receptor there responds to this genetic defect. And this is the total number of cases that we have in our registry now. This is just neonatal diabetes, not MODY. About 300 odd cases of neonatal diabetes. And then we have genetic syndrome. See, sometimes they come saying it's type 1 diabetes. And then when we screen, we find they have Walcott-Rollinson syndrome. They have short stature, liver is affected, kidney will later get affected. And children with Walcott-Rollinson syndrome do not become adults. They'll die before that. They'll die when they're 16 or 18, or maximum, I think, is about 20 years reported in the literature. So if you know that, you know the prognosis. And similarly, whether it's DID-MOD or, see this one, TRMA, thiamine responsive megaloblastic anemia. Child will have severe anemia and severe diabetes. You just give thiamine to the child, vitamin, and both diabetes goes away and the anemia also goes away. So actually, it's kind of a miracle that we are doing. And therefore, the remaining part of my life, I want to spend on this and try to find out, because there are, our estimate is that there must be all monogenic put together, there must be about 3.2 lakh people in children in India, and we have only a few thousand diagnosed. So where are all the children going? They're probably dying because they're not, nobody at age of 2 days of life or 1 month of life thinks of diabetes. They'll go there, they'll think it's meningitis or COVID or something, and then the child dies. So we have to pick that up. Okay. And congenital hypoglycemia, the opposite condition, where you get hypoglycemia, which can be treated with diazoxide, octreotide, if you find the right gene. So in November of last year, on World Diabetes Day, our health minister inaugurated a Center for Monogenic Diabetes. I think it's the first one in Asia to be set up. And we already started getting samples from all over the country for monogenic diabetes testing. So if you're interested in this, please let us know. We also have a register called as monogenicdiabetes.in, and it will tell you how to get the consent form, how to send the blood samples, and so on. And don't worry about money. If somebody cannot pay, it's completely free of cost. I pay for it. I look at the thing from my own personal donations, plus the families, plus ICMR's donations. So this is my humble journey in diabetes, starting from a dilapidated garage in 1972. And we had to get rid of the bats and the rats and start our work till where we have reached today. But all this would not have been possible but for my wife. In 1991, when I left my father, I was in a big dilemma because I had no money, I had nothing. And she said, we have the brains and we have our hands and we have our knowledge and we have God's support. What more do we need? We don't need anything else. And she was right. And I think it's her passion, her support, which has brought me to where I am. But there's also two other people, my daughter and son-in-law, who have been my third generation, and they have been pillars of strength. Of course, each one of this is like my child, and they're all people who have been stuck with me for 20, 25 years. Many of them work for 25, 30 years with me. And each one has taken a department, built it, and taken it to its rightful conclusion. I'd like to end with this quote from Jagdish Chandra Bose, who said, when one dedicates himself, that can be herself also, wholly for a great object or cause, the closed doors shall open, and the seemingly impossible will become possible for him. It is not just my father. I went to many people, many visionaries in medicine when I started my journey, my second half of my journey, and even the first half of the journey with my father. And they all said, you won't do it. They all told me, no, it's impossible. You're just dreaming and you're just being over ambitious, and this is going to get into trouble. You will be, you'll dig your own grave and you'll get a heart attack and die, and all kinds of things they told me. And first of all, they told me it's not financially viable and it's all closed. I think 40, 50 years later, I've not seen that happen. And I hope that doesn't happen, because this is the land of India. And we in India can always pull off miracles thanks to innovation and our own jugaad. So I'll end by saying Jai Hind to all of you. Thank you.
Thank you, sir. As usual, that was an inspiring presentation. And also, you took us on a very personal journey, which is also going parallel to the journey of diabetology as a science in India. So that was a parallel journey of both diabetes in India as well as your journey have gone together. I think you have gone through, like many, many great people, you have gone through a lot of obstacles and you've overcome them at each stage. What gives you the strength for that? And what is the advice that you have there for all the youngsters who are listening to you, how to overcome the various obstacles and what keeps you going? It's a passion, I think, but please tell us more.
Yeah, definitely you need a passion and a focus and what you want to achieve. Sometimes it may not be clear. When I told my father I need a research center, I had not dreamed up Siriseri. I thought one small, 2 floors, 1 floor, something. That is what I had in mind. So that is one. And sometimes a dream only, you cannot sit and, I could not have dreamed of a Siriseri, government will give me 6.5 acres of land. How will I ever even think of it? Those are miracles which happen. But I think more importantly, it is building your own team, because you can never do it. Without Radha, I could not have done anything in that the thing. Without the epidemiologists in my team, Deepa and Shanti and all of them, Pradeepa and so on, I could not have done anything in epidemiology. Without collaboration, without Salim Yusuf, telling us and thinking big, I could not have got into pure with him. So I think we need to collaborate. We have to trust people. I know many people in India whom I have approached for collaboration. Neither they have collaborated with me, nor they collaborated with anyone. And I remember somebody from Kerala, I don't want to mention who it is, he told me, Mohan, they will cheat you, Mohan. They will cheat you. Don't give your data. Don't join them. They will cheat you, he said. I said, sir, where will they cheat and run away, sir? Because once they cheat, their name will be in mud. If you just write one letter to editor somewhere, they are finished. No, I don't believe. You're being too generous. They will cheat you. They will cheat you, he went on. I don't think they'll get cheated. Of course, I've got cheated in all my life. Out of 900, maybe 5% of the time I've got cheated. 90 of that, I didn't mind that. Even recently, I got cheated. But it doesn't matter. I'll just say I don't need it. If that guy doesn't think he should put my name in a paper or something, that's fine. You just forget it. I've got enough things to do. I think you must have a large heart and you must trust people. Trust your own colleagues and trust your collaborators. Because it's all about, I have written in my book, saying that either you can have a big cake and have one piece of it, or you can have a small cake for yourself. That small cake may not even be 1/4 of that piece that you have. So I'll give you one thing and I'll stop with that. When I started Pure, I already started Cures. So Salim Yusuf told me, see, we're doing Pure, Mohan, where you come one city in Chennai and with the whole world. What are you comparing? Just give up Cures, he said. Just give up Cures and focus on Pure. I said, with due respect, Salim, I'll join you fully in Pure. I'll be there in everything, but I want my Cures. I want to continue with that. 160 papers describing the Indian pattern. I don't think Pure would have ever given that, because Pure has to focus on the whole world. So they cannot focus on India and give you, the complication, the retinopathy rates. And first of all, it's not a diabetes study. It's a completely different study. Pure is a diabetes study. So I'm glad I didn't give in to him. And I said, I'll keep my Cures and I'll continue that. But whatever you want in Pure, I'm there. Now, people say you could have done Cures. Why are you wanting Pure? Well, that's at answering different questions at a different level. So I think if you wear different hats and then you decide to collaborate with people and get the best of the people to collaborate with. Harvard, our collaborators are Walt Willett and Frank Hugh, the world's second and third of, you take the world scientists, I think in the first 10 in the world as far as H index is concerned. Salim Yusuf is there, Walt Willett is there, and Hugh are there, Frank Hugh are there. All the three are my collaborators, So I think if you combine with the best, it'll rub off on you. Something that of theirs will rub off on you. And of course, you also give something in return. Also, you can dream big. I don't think there's anything wrong in dreaming big. Don't become a dreamer and not do anything about it. But no harm in dreaming big. I think if you do that, I think then the sky is the limit, or even the sky is not the limit.
Thank you, sir. And it was really inspirational listening to you, and big appreciation from all of us. May all of us inspired to follow your footsteps. And once again, good wishes with you for continued success of your organization and for your health and prosperity. Thank you very much, sir, for joining.
Thank you so much. God bless you, and wish the rest of the meeting all success.
Thank you, sir.
Thank you so much for inspiring lecture, sir. Actually, we remembered Mission Mars movie. So your journey is like Mission Mars in diabetology. Thank you, sir, for inspiring lecture.
Thank you.
So now moving ahead in therapeutic perspectives, I would like to invite Brigadier Dr. Anil Pandit, Brigadier Dr. Satyanand Kadlur, sir, and Dr. Karthik Rao to chair the session. Dr. Pandit, sir, is our Chief Medical Director. He is an experienced hospital administrator with a demonstrated history of commanding many super specialty hospitals in armed forces for about 35 years. Skilled in handling with due diligence in hospital operations, commissioning new hospitals, new hospital projects, turnaround of ailing hospitals, telemedicine and hospital marketing. Astute academician with the MD in Hospital Administration from AFMC Pune and DMB from NBE New Delhi. He is a recognized postgraduate teacher and examiner for MD Hospital Administration and PhD in Healthcare and Hospital Administration. He is postgraduate teacher and examiner for National Board of Examination. He has published many articles, and presently we are fortunate to have him as Chief Medical Director at Chilaram Hospital in Pune. The next chairperson, Dr. Satyanand Kadlur, he was brigadier in the army and he worked with us in Chilaram Diabetes Institute. He is presently working with Ramesh Hospitals, Guntur as medical director and HOD medicine. Third chairperson is Dr. Karthik Rao. So Karthik Rao is Associate Professor, Department of Medicine at K.S. Hegde Medical Academy, Mangalore. He has done MD in internal medicine from KMC Manipal and DNB in internal medicine, granted fellowship in diabetes by Manipal University, worked with many institutes and hospitals, published several research articles in non-communicable diseases, actively involved in various community diabetes screening and awareness camps, and is working with many NGOs. Over to you, sir.
Very good evening to all of you. Today, we are coming at the fag end of the activities. We are going to talk on in this session, therapeutic perspective. And I got co-chairpersons, Dr. Satyanand Kadlur and Dr. Karthik Rao. In brief, I will tell about Dr. Agam Vora, and he is going to speak you on influenza and diabetes 2022 perspective, and Dr. Karthik Balachandran, he is going to talk on sulfonylurea in 2022, still standing tall. Now I call upon Dr. Satyanand Kadlur to speak briefly on Agam Vora. Thank you. Dr. Satyananda, please.
I'm extremely grateful to the organizer of this summit because CDI, Chalaram Diabetic Institute, remains my alma mater in the second innings. I'm extremely grateful to you, sir. So the topic of today is very interesting. We'll go back to 1918, Spanish flu when it came, when mankind was trying to find out very many cures for that. And only they came closest to the cure was the blood of the suspected or suffered flu persons were giving some improvement when the same blood was infused to the flu patient. That is precisely the beginning of a vaccine. So now that has still become more relevant now in the COVID era, where the vaccines are the talk. How exactly the influenza vaccine, which is generally almost marketed twice a year, it is changed because of the changing mutancy of the virus. So how it is going to benefit our diabetic population? Here is Dr. Agam Vora, who is a prolific speaker. He is a spiritual person, multifaceted personality, who has got many poems and books to his credit. And he's one of the physician to many of the spiritual leaders of our country. I request Dr. Agam Vora to present his deliberation regarding the vaccine and diabetes, especially influenza. Over to Dr. Agam Vora, please.
Good evening, everybody. Thank you very much for those nice words of introduction. And this scientific feast is about to get over. We are in the last few sessions of this wonderful CME, which was organized by the Chalaram Institute of Diabetes. And I'm extremely grateful to the organizers for giving me this opportunity. I remember my teacher, Professor Director Dr. K.C. Mohanty, who taught me respiratory medicine, 6th International Diabetes Summit. All delegates who chose to be here, it's just because of your presence, such programs occur, and that encourages us, all educational partners, for joining me. The agenda that I have in mind today is to talk about vaccination